School of Medicine and Pharmacy, College of Medicine and Health Sciences of the University of Rwanda. A brief of safety tip before we start the main session. We have our invited guests, our mentors, our professors already seated in the hall. We also have very distinguished panelists as well as participants and members of the university and Chub community. First is this hall. This is the grand auditorium of the Uye campus of the University of Rwanda. As we can see, we have two entries into the hall. Can we please check the entry? Look back to confirm the entry. We have to the right and to the left. And behind me here, we also have two exits to the right and to the left. Should in case there is an emergency, which we are not actually anticipating, but should it happen, there are 4 exits out of this hall. It's either you move, those of us who are on the front side can exit, like the DG will find his way through this door. Then our revered principal, being represented by our Deputy Dean of the School of Medicine and Pharmacy, Dr. Charles Muizi, and others will find their way through the side. Those of us at the rear would exit through the main entry into the hall. And then we have an assembly point outside. If you manage to exit through any of this side, the assembly points are outside there. Those of us from the rear will assemble just close to the registrar's office. So that is just about the hall. We also have convenience. To the entry into the hall, we have convenience for male as well as for females. So that's just a brief about the safety. And should the case we need to leave, let's just ensure that we allow one person at a time, just to avoid any form of rush that could jeopardize the chance of easy evacuation. Just like I said, since we have arrived, we have been networking with one another. However, we are going straight into the mainstream of the event. It is gratifying to note that the idea that led to this event today was conceived between July and August 2023. After the idea was conceived, in response to a call by Pfizer. Pfizer is an international pharmaceutical company based in the US for studies that could enhance and improve quality of care for patients, as well as reduce the threat of antimicrobial resistance. So colleagues from the University of Rwanda, as well as colleagues from Chub, had interactions to be able to say, okay, how do we respond to this call? The response was made, the concepts were put together, the submission was made. And by October 2023, the concept was approved. Please, can we give a clap to the entire team? The concept was approved, and then the activities commenced with signing of agreement by the DG and all partners from the Pfizer team. And from then till now, the university as well as the hospital has witnessed very tremendous activities in terms of workshops, training for healthcare service providers in the hospital as well as in the Chub and UR community. That's just a brief of a background, and several human capacity development activities have been achieved while the timeline of the project was on. So it is gratifying, and we are glad to have every one of us here seated to be able to learn from one another and also be able to appreciate the national action plan that the country has developed. Through the technical working group of the Rwanda Biomedical Sector as well as the Ministry of Health, several activities have been done to be able to ensure that we have what it takes to be able to reduce the incidence and the threat that are associated with antimicrobial resistance, improve antimicrobial stewardship, and be able to ensure that we have optimum patient care and delivery. So it's on this note that I would like to invite our DG, who are giving us all the support. In fact, we organize training up to late into the night. The DG will also be there to ensure that he monitor activities as it is anticipated. Please join me to welcome our DG, Dr. Garambe Christine, to give his opening remark. Please, we can still do more. Can we still do more? He's the father of the day. Today is the DG's day. He has given all it requires for the success of the project, and we are glad that many more of such will come. Welcome, sir.
Thank you, MC. Dear Director General of RBC, DGs of healthcare facilities, dear Deputy Fac Medicine, delegates from government institutions and hospitals, representative of Pfizer, all protocol observed, esteemed participants, distinguished researchers and members of the academia, I'm delighted to warmly welcome you to the much-awaited Antimicrobial Resistance, Antimicrobial Stewardship Symposium hosted by University Teaching Hospital of Butare. So it's truly an honor to see such a diverse and esteemed gathering of professionals, all united by a common goal, combating antimicrobial resistance. Antimicrobial resistance occurs when bacteria, viruses, fungi, and parasites no longer respond to antimicrobial medicine. As a result of drug resistance, antibiotics and the other antimicrobial medicine become ineffective, and infections become difficult or impossible to treat, increasing the risk of disease spread, severe illness, disability, and death, as listed by WHO. So antimicrobial resistance is a major health concern in Rwanda, and the country has developed an action plan to address it. The following predecessor, or just in 2024, Rwanda held the National Antimicrobial Resistance Conference to launch its updated action plan. The conference emphasized the importance of education, advocacy, and action. Studies have shown high rates of drug resistance in Rwanda, including among Escherichia coli, Klebsiella pneumonia, and the Staphylococcus aureus. The high rate of antimicrobial resistance in Rwanda are similar to those in other sub-Saharan countries, and the high rate of antimicrobial resistance in Rwanda are linked to the antibiotics that are commonly prescribed. The action plan of antimicrobial resistance in Rwanda aims to ensure that Rwanda has access to effective and safe antimicrobials. The plan includes activities to raise awareness about antimicrobial resistance in schools, the community, and the sectors, and the other sectors. The plan also includes activities to improve the use of antibiotics, such as reducing unsafe and excessive use of antibiotics. Antimicrobial resistance is a silent threat to global health. Antimicrobial resistance organisms spread quickly and can render modern medicine ineffective. with antimicrobial resistance, we risk longer hospital stays, higher mortality, and greater health costs. Over 60% of human infections are zoonotic, meaning they are coming from animals. Our convergence serves as a platform for collaboration, learning, and innovation, testament to our unwavering dedication to the cause. We have a rich array of topics lined up, each offering valuable insights and perspectives crucial to our mission and instrumental in shaping our strategies and initiatives moving forward. I am particularly excited about the opportunity to open discussions where we can exchange ideas, share best practices, and chart a course toward a future in which antimicrobial resistance is effectively managed and mitigated. Your input, experiences, and ideas are invaluable resources that will enrich our collective knowledge and inform future strategies. Together, let us seize this opportunity to exchange insights, address challenges, and forge partnerships that will propel us closer to our shared objectives. To our colleagues from CHUB, we thank you. Your dedication to excellence and commitment to serve are truly commendable. Your presence here today underscores your unwavering commitment to the health and well-being of our community, and I am confident that your contribution will further strengthen our collective resolve in the fight against antimicrobial resistance. To our partners from the College of Medicine and Health Sciences of the University of Rwanda, your expertise and insights are invaluable assets in our pursuit of excellence. I extend my deepest gratitude to your participation and look forward to the fruitful discussions and collaboration that lie ahead. I would like to take this moment to express our heartfelt gratitude to Pfizer for their generous support and funding to the capacity building project on the implementation of the antimicrobial stewardship and antimicrobial resistance surveillance here at CHUB. On behalf of CHUB and all those who will benefit from this initiative, I would like to sincerely thank Pfizer for their unwavering dedication and advancing public health and their partnership in our shared mission to combat antimicrobial resistance. Let us approach this innovative symposium with open hearts and minds, ready to learn, collaborate, and inspire change. I thank you all for your attention.
Thank you very much, sir. Can we please do more to give the DG? As mentioned by him, on the 28th to 22nd of November 2024, the RBC, through the Ministry of Health, hosted the National Antimicrobial Resistance Conference. However, the WHO, through the Awareness Week, had this theme. So you repeat after me. Educate, educate, advocate, act now. Can we do that again? Do we take a short break to go for tea break or continue? I want that to be much louder. Educate, educate, advocate, act now on issues about antimicrobial resistance and antimicrobial stewardship. So please, let's give the DG another round of applause. So the country is setting the pace. And in the region, as well as in the African continent as a whole, Rwanda is setting the pace And a testament to that is why we are also here this morning to continue the advocacy. While numerous educational programs through human capacity development activities are also being enshrined. And we are also acting. We are not just, we walk and then we talk. All are encompassed together. It is my pleasure and honor to invite the principal of the University of Rwanda College of Medicine and Health Sciences, Professor Abraham Mitike, ably represented by our own Deputy Dean of the School of Medicine and Pharmacy, Dr. Charles Moizi, to give us a goodwill message. Can we please give him a round of applause? Thank you very much, sir. Our father is the father of all, and we are delighted to have him here. Welcome, sir.
Thank you. Thank you. Good morning, everyone. Dear RBC Director General, dear Director General CHUB, dear Director General of Clinical Education, and our main collaborator in the CHUB, dear representative of Pfizer. It's a great honor to be here. By the way, I'm Dr. Charles Mohizi. I'm Deputy Dean at School of Medicine. I'm representing the principal of the school, the College of Medicine and Health Sciences, Professor Abraham. I'm not Abraham. So I'm representing Professor Abraham, who could not make it. He was very busy, but I was supposed to be here also, but I'm here to represent him now. So the School of Medicine is enjoying collaboration with all health professionals. As you know, we are almost same institution, and this topic is of great importance because, antimicrobial resistance, it's a worldwide challenge, and how to overcome it, we need, collaboration between all partners, especially health professionals. At the level of the School of Medicine, or at the level of University of Rwanda, we have the College of Medicine and Health Sciences. Our part in that fight is about educating, building capacities. At the School of Medicine, we are having, a program of, training program. We're educating, we have even the last 3 years, we have progressed a lot because we used to have 1 or 2 staff in the Department of Microbiology. Now we are having around 14, 15 in the department, and among them, 10 PhD holders. At the School of Medicine, we are also planning to start a program of masters. In September, we are starting the program of masters in infectious diseases, but also we are having also at the School of Health Sciences. As you remember, at the College of Medicine, we're having 5 schools. Among them, we have the School of Health Sciences. And some training are done at the level of the School of Health Sciences. Ours is the School of Medicine and Pharmacy. And it's increasing, it's a kind of, we have been improving. I remember in the past, students were not properly trained, but now, the last 3 years, with the good staffing, we are having, we are putting, we're emphasizing the training of students at the level of undergraduate. For example, in the past, the practicals were not well done, but since we have a good staffing, we are having every afternoon, we're having practicals every afternoon from Monday to Fridays, and students are enjoying. This will also encourage students to, after their studies, to continue their studies and to do these basic sciences, because the basic sciences was part of our target to, we used to be weak. I remember in past, 10 years ago, 20 years ago, almost 70% of our courses in basic sciences were covered by our friend from Belgium. And sometimes when there was some problems, they used to stop teaching. Can you imagine now, if we're still, still supported by those people, now it will be a catastrophe. But nowadays, we are having our own staff. And when you are training, some of the first of our best trainees were, our colleagues like Director General. And whenever we train people, sometimes, they are appointed in other government institutions because they are needed everywhere. And nowadays, we are aiming at training more and more so that we can have at least staffing. It was a great problem, and you cannot do medicine without basic sciences, a strong teaching of basic sciences, and that was our weakness. I can give an example. The microbial department used to be, I think, one or two. It was only you, I think, one or two. Anatomy was one-man show, Professor Gashego. And biochemistry, the same thing. But nowadays, in each department of basic sciences, including microbiology, we are having at least 10 or 15 PhD holders. That's a great move. And you are aiming at continuing in that, the trend is continuing, and we will have at least more and more staff. Especially in September, we are starting the new program of medical, infectious disease master's degree. And at the level for School of Health Sciences, they are starting the program of medical microbiology. This, when I'm talking about microbiology, so the challenge of antimicrobial resistance, it's a bit that you are not organizing so many, because this kind of discussion between experts, we have to encourage this kind of session, this event, because we need them, because as doctors, sometimes we are not practicing well because, to address the issue of antimicrobial resistance, it's a big problem. Fortunately, I hope it's the first one, and we have more occasion to discuss. And I wish during these next 2 days, we are having, fruitful debate to address those issues. I just regret because we don't have enough students here. You didn't resist my student. You should have resisted my student coming here. I would expect this room to be full of students. Otherwise, because they have to be aware of the situation at the early stage. So mine is just goodwill message. The School of Medicine, the University of Rwanda is very supportive. We always be together to address those challenges. Murakoze cyane. Thank you very much.
Thank you very much, sir. Can we please do more? Just like I mentioned the other time, he is our father, he's our mentor, Dr. Charles Moizi, and he represented the principal, the College of Medicine and Health Sciences, University of Rwanda, Professor Abraham Mitike. A round of applause again. Thank you. While that was on, it is also interesting to note that just like the principal had mentioned, that the country is taking the lead. And just recently, and I'm also glad that the co-PI of the projects on human capacity development, on vaccine manufacturing, and other concerns is also here, Professor Ezra Agu. Please, a round of applause for him as well, too. Through that project alone, a new PhD program is to be announced for admission process anytime from now, and by September, the first cohort of the program will be will have the admission process completed. In similar manner, we also have 10 new master's program, 10 new masters, brand new master's program. One of such is MSc Infectious Diseases, Masters of Science in Immunology, Masters of Science in Clinical Pharmacy and Therapeutics. That's 3. Masters of Science is in Experimental Animal Model. We also have Master of Science in Human Genomics and Genetics. We also have Masters of Science in Bioprocess Engineering and the likes. So the programs have gone through various stages of commendation. And hopefully very soon, the admission process will be announced, and we would be privileged to have further enhancement of our capacity in-house, as well as the region and the African region, African continent as a whole. I also wish to note that this symposium is being live streamed. Please get the link is being shared. Kindly assist to facilitate to other colleagues that are not here physically. It's my honor to invite Dr. Blaise Pascal Ishimwe to give us his goodwill message on behalf of Pfizer USA Incorporated. Thank you very much, sir. So Dr. Ishimwe is one of us, and he will still continue to be one of us. And we hope that this is going to be the initiation of several other collaborative projects to come. Please, you have the floor, sir. Thank you.
Thank you, MC. Thank you so much. Dear RBCDG and dear CHUB DG, distinguished guests, it is my honor to stand before you today as we continue collaboration in this journey in tackling one of the most pressing global health challenges. At Pfizer, we firmly believe that access to quality healthcare should not be determined by where you live or your financial status. Through Accord for Healthier World, we are dedicated to bridge the healthy equity gap by expanding access to essential medicine and strengthening the healthcare system worldwide. Our commitment extends beyond delivering medicine. We are committed to actively invest in health system resilience and enhance the capabilities of healthcare workforce. As part of this commitment, we have provided various grants, such as the one that UR and CHUB have got, and deliver multiple continuous medical education program to equip healthcare professionals with knowledge and skill needed to improve patient care. The partnership are at our heart of mission. By working closely with stakeholders like CHUB and UR, we can deliver meaningful change and impact Rwandan patient outcome. This IMS-IMR surveillance initiative is a key priority, and we remain steady first in our commitment to continue this collaboration to bring healthier and more equitable world for all. I sincerely thank you for your dedication and collaboration, and I look forward to a fruitful discussion and impactful steps we will take together. I thank you and appreciate the invitation.
Thank you very much, sir. You can see that money does not talk too much. Do you see that? You know me, I've been talking. He just came, he gave his presentation in less than 2 minutes, and it's done. So that is the power of money. Please, can you please clap for Pfizer? So we are sending a very strong message to you through the entire team at Pfizer that this is an initiation. Through the project, through the various assessments that were done, there are so many more to be achieved. And during Dr. Joe's presentation, he shall give us the milestone, particularly in the quality improvement plans that this project was able to achieve, aside from the various other human capacity development that we're able to achieve. And they are all here seated in the hall. Whatever you tell you that this was achieved, there are witnesses to confirm that. Just like our principal mentioned the other time that the School of Health Sciences, the Masters of Science in Medical Microbiology had commenced, first cohort started in December 2024. The faculty members are also here. The students too are also here. Please, students in the MSc Medical Microbiology program that are here, please, could you please stand up for recognition? I will not mention your name. Please, could you please stand up for recognition? Yes, thank you very much. We have about 18 of them. Others are at the Remera campus and they are also doing very well. They have joined online. In that regard, I would like to invite the DG RBC, Professor Claude Mambo Muvunyi, is with us at the Department of Microbiology and Parasitology, as well as the head of RBC, to give his goodwill remarks. Please, a round of applause for our DG. You can see that it's very simple, but he's a globally recognized clinical microbiologist and infectious disease expert. In June, the country Ministry of Health as well as RBC will be hosting the EDCTP conference, which is also a testament to the quality of his leadership at RBC. Can you please do more to welcome me once again, sir? Welcome.
Thank you very much, MC, Doctor. Good morning. Good morning again. Without going into much protocols, I'm very pleased to be here with you today on this special, a very important symposium on antimicrobial stewardship and also antimicrobial surveillance. I think, first of all, I'd like probably to express my gratitude to the Butare Teaching Hospital, University of Rwanda, for really organizing this crucial event, but also to thank FISO for the support to our effort to strengthen our system to fight against antimicrobial resistance. It's also a very huge pleasure for me to be here for many reasons. First of all, I think the last time I was in this Grand Audi was more than 20 years. I was here most of the time for watching movies and so on and so on. But today I think it's really a good pleasure to see that this room is used for some very important discussions and also meetings, where I think at that time we were not used to discuss about antimicrobial resistance. But today, I think 20 years ago, is a very good opportunity to discuss about antimicrobial resistance. And if you remember this theme on educate, advocate, and act now, I think I want this symposium to be an opportunity not only to be a symposium, but really to make sure that we come out of this meeting with actionable resolutions, so that we don't only act now, but probably we should have acted yesterday to be able to tackle issue of antimicrobial resistance. I think if you ask me why we need to put much effort in this topic, is first of all, I think sitting at Rwanda Biomedical Center and assessing where we were more than 10 years ago and today, I think we have made a very huge achievement in controlling infectious diseases. But today, I think we are challenged by antimicrobial resistance. So we are no longer able to continue to eliminate disease like malaria, where we see now cases of resistance due to antimalaria. And if you also consider other diseases like TB, HIV, I think today we are challenged is preventing us to continue to control those infectious diseases. Second, I think if you consider other diseases or infectious diseases which are caused by pathogens, which I think more than 10 years ago was easy to treat. But today, I can tell you that if you go to the hospitals, you'll find very simple infectious disease not able to be treated. And also, I think simple medical procedures today are really challenged also by the risk to get antimicrobial resistance pathogens in the hospitals. So you can imagine that this is a very, it's a really problems that we are facing today. And I hope that if we are here today to discuss about the antimicrobial resistance, because I think if you continue to do normal business in the future, we want to be able to treat diseases. We may not be able to have effective antibiotics, or we may be able to oblige to be treated with antibiotics which are very expensive and not affordable by most of our populations. And for me, I consider that antimicrobial resistance concerns everyone. And if you ask me what are the chances or risk of being treated by antibiotics, I think most of us, we may be candidate for antimicrobial treatment. And if you don't do something now, we may not be able to be treated in the future. And if you consider now today's many procedures like surgery, chemotherapy for cancers, they're all opportunities for treating with antimicrobial resistance. So I think this again, another very important reasons to continue to focus our efforts to discuss those issues of antimicrobial resistance, but also making sure that we have clinicians, pharmacists, and everyone, even the community, being aware of the issues, but also being educated on how to work together to really come up with interventions to really tackle these antimicrobial resistance problems. Again, this symposium is a very good opportunity for policymakers, doctors, students, researchers to share some experiences, insights, findings, and also solutions to the antimicrobial resistance, which I think is something we need to continue to put much effort as we continue to deal with other challenges. Again, Rwanda Biomedical Center will continue to support all the efforts. I think we all know that recently we had our action plan against antimicrobial resistance, which I think for us need to be interventions which are well coordinated, which uses collaborations, a multi-stakeholder approach, but also using evidences to really design good interventions around public awareness, research, surveillance, antimicrobial stewardship, and also other innovative solutions to continue to tackle this antimicrobial resistance. So again, I'm also very glad to hear today that we have what we need to really continue to have the knowledge, but also the capacity that the University of Rwanda is having now, the teaching hospitals. It's really a very good hope that the solutions will be there very soon, in a short way. And I'll continue to really encourage the University of Rwanda and teaching hospitals to have several occasions of these kind of symposiums where this topic is going to be discussed. Last but not least, I think I got the invitation from DG and the head of the clinical department. First of all, I say, okay, maybe I can delegate someone to come and do this for me, because I also other commitment to Kigali. But because of the bias that I have based on my expertise, my experiences. I think I really decided to be with you today. So I think this is something I would like to encourage you. And the last but not least, I would like again to thank the Butare Teaching Hospital, the University of Rwanda, and FISO for really organizing this symposium, but also encouraging you to really share a lot of lessons, but also coming from this symposium with really clear and very actionable recommendations. And I hope that you'll have a very insightful discussions during this 2 days symposium, and maybe Rwanda Biomedical Center will be happy to continue the discussions and also continue to organize similar discussions or symposium in the future. So thank you very much for all and everyone who has been beyond these organizations, and also to the presenters who are going to really share their knowledge and expertise during these 2 days. Thank you very much for your kind attention.
Thank you very much, sir. Just like Prof had said, he's quite very passionate. And those of us who are familiar with his publications online, we also know that he's taking every lead as a professional, and also as an head of institution, providing all the mentorship that is required. I'm one of your followers on Twitter, on X. So whatever comes, I'm always very close to appreciate the fact that we have the new updates, and we are all very glad that we know what we expected to do. In November, when the NAP2 was launched, the various components were very explicit, and all that is required in terms of resource mobilization and the likes were clearly spelled out, and the leadership is driving the force through all the necessary stakeholders' engagement to have the goal achieved. So on that note, on behalf of the team at Chub and the entire colleagues from UR and Pfizer, we are delighted that your leadership is providing the necessary framework for improvement. I want to take a break to inform us that for the symposium, we have specific lines of activities, and as it has been communicated to us, we'll be having the minister's keynote address, which will be delivered by our DG. Once that is completed, we'll have a short tea break. Then we'll have a group photograph here. Thereafter, the minister's keynote address, once it's completed, will declare the symposium officially opened. Then we'll be mentioning NAP2, NAP2, NAP2. What do we have in the National Action Plan 2? Dr. Musba Gashegu is also here. He's also very passionate. And as a focal person, he will lead us into all the necessary details that we're expected to know about the Rwanda National Action Plan on Antimicrobial Resistance 2024 to 2029. Once that is completed, we'll be having the first panel discussion. The first panel discussion is to review efforts on monitoring antimicrobial resistance in Rwanda. And we'll be having our panelists from various institutions of learning. Then we'll have question and answer to wrap up that session. Once that is completed, we'll be having the reports on capacity building on implementation of AMS program and AMS surveillance at Chub, which is going to be delivered by Dr. Jules Ondoli, our mentor, our teacher. Thereafter, we'll break for lunch. Lunch will be served at Koika ground floor. We'll have a protocol that will lead us into the lunch session. Once the lunch session is over, then we'll have the scientific session. Just like I mentioned, we have 3 components for the symposium. Majorly, we have the panel discussion session. We're having three panel sessions. very much. Uh, so once lunch is served, okay. So once lunch is served, we'll be having the first oral presentations, 4 presentations at that session. Thereafter, we'll break for the second panel discussion. We also have the second panel discussion is on antimicrobial stewardship program. How best can we implement? How also can we tackle the challenges that are associated with them? That will be followed by question and answer, and then we'll go into the third panel discussion on strengthening partnerships for sustainable AMR and AMS and AMR interventions. We'll also have our team of speakers. Then the second oral presentation will also be ushered in, and then we'll wrap up for the day. In the evening, we'll now have a cocktail, which is going to serve as a medium by which you network, interact, and then unwind, as the case is. Then we'll wrap up for today. Then tomorrow we continue in similar approach. But for tomorrow, there won't be any panel session. We'll only wrap up the oral presentation as well as the poster presentations as anticipated. So thank you very much for your patience, your interest, and your support thus far. The next line of action now is for us to have the group photograph. I was made to understand that the speech delivered by the goodwill message by the DG has encompassed all that in his capacity as also a representative of the Minister of Health. And we are delighted that we've managed the two together. So now I will request protocol to kindly assist to arrange the chairs here. The dignitaries will be seated while all participants would queue up behind them. We want to have this banner projected. Thank you very much. So please, we have photographs. Our items are safe. Please, let's just stand up and then we join the photographs. Thank you very much. Please, let's stand up. We are all invited for the photograph. Everyone is invited for the group photographs. Thank you very much. Okay. Members of the organizing committee as well as the invited guests should please be seated while we take the photograph. Thank you very much. Other participants, please. Let's take the tea section to the left for our tea break session. Let's go for our tea break session to the left. Thank you very much. Yes. Management team from Shashube, members of the organizing team as well as project members, and invited guests from the University of Rwanda should please be seated. Heads of department that have been invited and our professors in our midst should please be seated for the group photograph. Please, let's stay together. Okay, Dr. Adeyemo. Malam Yakub, you are also a member. Please come over here. He manages the ICT for the... Dr. Tulesa, HOD Biochemistry. Thank you very much. Mr. Yakub, ICT, please come over here. Thank you very much. We thank all our professors for honoring our invitation. We are delighted. Thank you very much. Thank you very much. So now we invite so it's time for tea break, please. Tea break. Tea break, tea break. Please let's stand up for tea break. Tea break. 15 minutes of tea break. Please to the left or to the right.
Nigaragaza biguye ingangara ingeri zayigize umutwari inka y'urukundo mugabo wigema aho batinya inkuba zishinze imyaka y'ingoma rutebeza mugana mpabuka impanga z'amihigo yo muzamato bitabangira iminega y'indekwe ihora ishinzira igugenda mutsindurira yumva ntiti ikaba rwiyabirira ihamije iminega rwa mirindi ya mpabuka urugamba ntiyega yezu yenzi ntiyimirwe ikaba shebuja w'impanzi
twamaze ishyanga ubu twese tuganje mu rwatubyaye kakarama yahiye n'inyangamutsindo niko katunganywe kw'izina umunyarwanda emera mvunyishe nyamiratsi nyamibwa yanyuze ijambo ngundi rumeze ijabiro cyangwa unkomere yombi kuwamariye utikame nanone azahora kwirahira yagabyinka mu gihugu ngo arwanye ubworo ubugerera mu Rwanda yongeye kuba indamutso umwana w'umunyarwanda aranywa amata agahaga amavuta atisiga umwera aho wawubonye emera mvunyishe nyamiratsi nyamibwa yanyuze ijambo ngundi rumeze ijabiro cyangwa unkomere yombi kuwamariye utikame nanone azahora kwirahira ndangurura ndirimbe nsingiza uwangabiye sinanywa n'inkikirego umukinzi mbamuroga iyo tubona amahoro aganje mu Rwanda ibyo byatuma twese tumwirahira emera mvunyishe nyamiratsi nyamibwa yanyuze ijambo ngundi rumeze ijabiro cyangwa unkomere yombi kuwamariye utikame nanone azahora kwirahira iyo ngabire y'Imana yahaye u Rwanda ibihugu n'amahanga byararondogoye bikubarira imyaka sibo baruhaye abanyarwanda twese turi inyuma yawe emera mvunyishe nyamiratsi nyamibwa yanyuze ijambo ngundi rumeze ijabiro cyangwa unkomere yombi kuwamariye utikame nanone azahora kwirahira emera mvunyishe nyamiratsi nyamibwa yanyuze ijambo ngundi rumeze ijabiro cyangwa unkomere yombi kuwamariye utikame nanone azahora kwirahira ngwino mama ngwino shenge aho nahereye muha amazi kandi ziwanyu zikamwa zose amarwa yuzuye intango kandi n'ubuki busesa impinza ngwino kibondo mujyane iwanyu iyo ababyeyi bahoza abana
banga guhora bakabahendahenda bakabahongera ababaheka nugerayo bazaguha amata baguha impenge usomeza ishyushyu n'umutobe uzakumara inyota kandi n'impungure zihoza abana urihe manurira urihe ngo muhoze nifuza ko waziwanyu mu mata bateza agatemba ko biganza bikabamariza n'aya nyambi inogeye amaso n'aya nyambi inogeye amaso
inamusetsa numva gute nyorotse rwose umuheto ukunda gutakisha uwarakarita wari sinawutsinza mugabo nga mbere n'umutasi gusa kuntabaza umuseke wa kare gusa gusa sanica
ngwinore menye umuravumba n'igicushu n'igiti cy'umuvumu ndetse imbehe n'inkongoro niho biva dore isekuru n'umuvure ngakwa akamaro k'umuvumu urankujyanirya bega kwa bikina usangeyo ujegera n'isabukuru baziretere bazinikize maze nkayabagunga igukamirwe kozwa na nyabarongo ayiwe nyabarongo umugezi utemba uramba mihorere none uramba mihorere none uramba mihorere none uramba mihorere none sinarinze uko inzara iryana nabibwiwe na nyina wundi narabwiriwe ndaburara mu gitondo ndabusubira nizirika agashumi mu nda ayiwe mbebazaho ziragatwaka yego kwiringira kwibeshya wiringira inkumi mu nzu ukibeshya uracyuye mu gitondo ikagutamaza ayiwe byari bikaguta mu nzu uramba mihorere none uramba mihorere none uramba mihorere none uramba mihorere none igihungu cy'icyomanzi kimwe kitagira iwabo cyabonye ubukwe butashye kijya kwambaza rya ngombe muransindira iki gitero ngo yiwe mu gitondo ndaguha intambo igikobwa cy'icyomanzi cya kindi cy'ikigenge cyabonye ubukwe butashye
Suzana we garuka burya ishavu ntawe ryica maze kubibona Suzana mba narapfuye nzizu urukundo rwawe byari byaranyobeye uko nzabigenza n'impamo nibwo nakwandikiraga kabarwa nkugarura mukunsubiza undemwa agatima umbwira yuko turara tubonanye dore imyaka irashize sheruma ze kugenda ntazi impamvu yakujya nyukansiga njyenyine nagutumaho ukansubiza kuzaza nagutegereza sinkubone wowe sheri nzagira nte ese ko ngiye gupfa kutakubona njye biranzahaje ashi Suzana we ntubigenze utyo ngirira bwangu igihaha cyarashiriye ngarukira bwangu Suzana Suzana ndagukunda Suzana kora uko ushoboye kose mazu ungarukire reka kunyisha agahinda nkaho nakwiciye nibuka igihe twari kumwe kumumena twaganiraga ibyerekeye ku buzima.
Thank you very much. We are moving into the next session, which is to have the presentation by Dr. Musba Gashegu, Director of the One Health Unit, Rwanda Biomedical Center, who is also the National AMR Focal Person of the Ministry of Health, RBC. So it's my pleasure to have Dr. Musba Gashegu have his presentation. However, I want the protocol to please adjust our sitting plan. Let's move towards this side. Please take your coffee or tea and then you maintain your seat. Please. Okay. Thank you very much. The projection is on the screen there. Protocol, please kindly assist to mobilize all participants to their seats. Once this is completed, then we'll move over to the panel discussion. Thank you very much, sir.
iminsi yanze ukwimanya myinshi umutwaro cyongwe n'uhunyayikire ibyo ngutekereza ni byinshi ariko kandi ni mu gihe umuhoza wanjye wandutiye benshi bisabe umuziranye uwo mu mata bateze neza.
Good morning, everyone. Muraho, mwaramutse, mwiriwe. So thank you, Dr. Taufik, for granting this opportunity to present the National Action Plan on Antimicrobial Resistance to the audience here in the auditorium of University of Rwanda. So my name is Gashegu. I work for Rwanda Biomedical Center as the director of One Health unit. And I'm also the national focal point on antimicrobial resistance surveillance here in Rwanda. So I'm glad to be in front of you presenting to you the National Action Plan on Antimicrobial Resistance. So briefly, I would like to share with you the Rwanda One Health Multisectoral Coordination Mechanism. So because this National Action Plan has been really developed by multisectoral team. When we talked about multisectoral team, it means that it has been developed in One Health approach, whereby we do have different stakeholders who have been contributing to have this National Action Plan revised and launched. So at the top level of the One Health Multisectoral Coordination Mechanism, we do have the Prime Minister's office. Actually, the Prime Minister's office is the top leadership, is the top leader of the One Health Multisectoral Coordination Mechanism, whereby we do have a social cluster of the concerned ministries. So we have concerned ministries of the One Health. It all depends on the emergency or on the interventions to be implemented. So, but the lead ministry of this social cluster is the Minister of Health. And it does have also Minister of Agriculture, Minister of Environment, Minister of Justice when we go to the forensic labs. So we do have RDB. All those are really the cabinet members which are to report to the Prime Minister's office. So then below we do have One Health Multisectoral Coordination Mechanism, which is made by the heads of institutions, heads of implementing institutions, including Rwanda Biomedical Center, Rwanda Agriculture and Animal Resource Development Board, we do have Rwanda Environmental Management Authority, we do have University of Rwanda, all of those implementing entity, they are under this One Health multi-sectoral coordination mechanism. But this OHMCM is being led by the coordinator, who is appointed by the Minister of Health, which is the line ministry of the One Health platform. And currently, we do have a DG of Rwanda Biomedical Center, who is the chair of that OHMCM, Prof. Claude Muvunyi. So he's the one who is coordinating all other institutions. So nearby, we do have One Health Secretariat. This is a unit under RBC, which overseeing the implementation of all those strategic documents approved by the One Health platform. Then after, we do have a very important part of technical working group. Actually, without technical working group, we can't really implement, we can't really have the success of any achievement. So we do have different technical working groups. Everything we do it into technical working group under the leadership of One Health multi-sectoral coordination mechanism, then being facilitated by the One Health Secretariat, which is the unit we are working with. So we do have different technical working groups, but the most important one for today is the technical working group 1, which is food, crops, plants, drug safety, and antimicrobial resistance. So this technical working group is the one which does have the sub-technical working group at national level on antimicrobial resistance, and it does different stakeholders, including those implementing entity and hospitals, of course. Thank you to all of you who are really providing staff. Thank you, DG Sashwibe, all the time when we invite your staff just to support or to contribute into the national initiative. We always have a presence of Sashwibe. So thank you so much, DG, for really considering this initiative. So from all those technical working groups, we have been really having achievement. So we have been come up with some of the strategic documents that have been really developed, launched, and endorsed. So we do have, first of all, the policy, One Health policy, which is a legal document establishing the One Health initiative in Rwanda. So from this One Health policy, we came up with having strategic plan of One Health, and also National Action Plan on Antimicrobial Resistance. This National Action Plan on Antimicrobial Resistance is really a multi-sectoral document whereby we do have the interventions for the human health sector, for animal health sector, for even for environmental sector. So from this National Action Plan, which does have 5 strategic documents, 5 strategic objectives. So we came up with having a surveillance strategy on antimicrobial resistance. So as of now, we do have a surveillance strategy at national level, by which it is being really guiding the facilities to implement the antimicrobial resistance surveillance. So from the surveillance, we go to stewardship. As we are having a theme for today's symposium, which is educate, advocate, and act now. Actually, this theme is the theme for World Antimicrobial Resistance Awareness Week. And we do have also stewardship aspect. So we have been really having a stewardship guideline in healthcare setting. So we do have at national level stewardship guidelines, And currently, we do have a national action plan on antimicrobial resistance, which is phase 2. So the NAP 1.0 has been really ended last year, and as other speakers just mentioned, they mentioned that we are now implementing the phase 2 national action plan. So, and thank you to all members of the technical working group who have been really contributing to have this national action plan 2.0 really developed and launched. It has been launched in last year, in November, during WOW week. Thank you all for your contribution. So from there, actually, if we can maybe go straight to the topic of today, the National Action Plan 1.0, it has been developed and also implemented for the last 5 years. But we had some of the challenges of implementing this National Action Plan. That's why it has been implemented at 34%. It means that 66% has not been developed, has not been implemented. And we came up with implementing some of the initiative or strategic objectives in regard to awareness. It has been implemented at 38%, evidence-based 34%, governance 67%, and practice 12%. So governance, it's quite higher because during that period of time, it is when the government of Rwanda has established the governance of One Health, whereby it has been establishing the One Health unit within Rwanda Biomedical Center to really ensure the implementation of the National Action Plan and other One Health strategic document. So what is new with the National Action Plan number 2 or 2.0? So the new from this is that first of all, when we go to multi-sectoral aspects, it has low involvement. The NAP 1.0, whereby environment and plant health were not really fully represented. And this has been the new one, which is 2.0. It has the full involvement of different stakeholders. When we go to the monitoring, the evaluation, the NAP 1.0 hadn't have the M&E framework. You know that for the successful implementation of the plans, we need to have the monitoring, the evaluation framework. So NAP 1.0 doesn't have this framework, but the current one, which is 2.0, it does have the monitoring, the evaluation framework, which will be helping us to monitor the progress of the implementation. So when we go to the costing, actually the costing of two different national action plan are quite different, because the one for the previous one, the phase 1 NAP, had the estimated cost of the activities. But now we do have the costing, and this costing has been really done by the WHO costing tool. We do have a costing tool, which is a comprehensive, and it does help us to track each budget from each strategic objectives or each sector. So I will show you some of the hints there. So it has 5 strategic objectives, the NAP 1.0, but the current one, it does have 6 strategic objectives. Actually, we seated together into the technical working group and agreed to really add the strategic objectives talking about governance, because we have seen that governance was a challenge. It was not really highlighted into the previous NAP. So let us maybe go quickly to the process of development of this National Action Plan 2.0, actually it went through different steps, whereby the first step was to sit down within our technical working group and try to discuss on the prioritization of the interventions, because we shouldn't really came up with implementing without having the prioritization of the interventions. We can't really implement all interventions at the same time. Then we had an opportunity to work together with some of the partners. Policy Accelerator is a company from the University of York, from Canada, which has supported us to really use a smart choice process tool. Actually, they developed a tool called the smart choice process, and this smart choice process was the one which helped us to really prioritize the interventions. So we came up with having interventions prioritized depends on the priorities of the country. So this was the first activity that has been done. And then after having all those interventions prioritized, so we came up with having a monitoring the evaluation framework. So with the interventions, with the activities, we came up with then developing an M&E framework. Then from there, we have everything in regard to the document. Then we came up with having a costing of all the activities that have been detailed into the document. So thank you to WHO, which has been supporting us on this WHO costing tool. So this was really the process of having this national action plan well revised and launched. So if you can see on the picture, on the slide, we do have a picture of some of the members of the technical working group, which were sitting together discussing on the prioritization. So actually, prioritization was made in One Health approach. We had different stakeholders and different partners. Then we came up with on the agreement of prioritization. So very soon, this National Action Plan will be published on the website of the Ministry of Health and RBC, and each and everyone should be accessing the document. Actually, for your information, the National Action Plan, it has been really developed in line with the Global Action Plan. The one for the previous one, NAP 1.0, it was about the initiative of the member states for WHO. So when we go to the budgets, so the budget is quite big. Actually, we do have a rough budget of around 30 millions USD, and if you can see, it is really broken down by the implementing entity, So we do have the line budget of Rwanda FDA, University of Rwanda, One Health Secretariat, REMA, RAB, and RBC. Actually, all those are really the key implementing entity of this National Action Plan. So we do have also the budget in line with the strategic objectives. Remember, I told you that we do have 6 strategic objectives, and each strategic objective has its own budget. So that is really the strength of the costing tool, whereby you can extract the costing depends on the strategic objectives. You see, you know that the funders, when we have funders might be having really their priority, and to help funder really extract the cost or the budgets depends on the priority. We try to really separate the budgets in regard to the priority of the National Action Plan. So this is the current status of our National Action Plan. Actually, the National Action Plan 2.0 will look like this, and it is now under the process of being endorsed by the line ministries. Actually, so far, Minister of Health has already endorsed, this National Action Plan. It is now under the desk of Ministry of Agriculture, and then it will be followed by the Ministry of Environment. Then it will be published on the website, on several websites, including Ministry of Health, Minema, and Ministry of Environment, and also Ministry of Agriculture. So actually, I can't really stop by not really mentioning some of the opportunities that we do have to really try to implement some of the initiative or some of the interventions that have been highlighted into our National Action Plan. So we do have, thank you to Pfizer. Actually, Pfizer is helping is helping facilities to implement some of the initiative of antimicrobial resistance, surveillance, and as well as stewardship. Like, for example, this symposium is being funded by Pfizer, and there were some of the interventions that have been really made by some of the facilities under the Pfizer grant. So thank you to Pfizer for your opportunity to really try to improve the quality of health services in our healthcare settings. Thank you so much. So, thank you. I can't really stop by not really mentioning some of the great initiative that has been made by CHUB in regard to the surveillance on antimicrobial resistance. Actually, we do have currently a challenge of really reporting some of the AMR data, antimicrobial resistance surveillance data. But now, CHUB is really benchmarking, is really taking, we are considering CHUB as a benchmarking or as an example of a hospital which tried to really accommodate the WHONET. WHONET is a global platform from GLASS, from WHO, which is really showing all the indicators that should be reported into global platform on antimicrobial resistance. So thank you to CHUB for the initiative that has been made. And thank you. And at national level, we are now trying to benchmark what CHUB has made to really try to take it to other hospitals so that we can have at national level a global or a national platform on antimicrobial resistance. So all this has been really made under the support or under the funding from Pfizer. Thank you. So we do have other opportunity of Rwanda National Antimicrobial Resistance Prevalence Survey in human bloodstream infection. Actually, this is a survey which will be implemented into 35 facilities. And this survey, including CHUB, of course, and CHUICA, and all other university teaching hospitals. So this survey will be helping country to really have the estimate on antimicrobial resistance at national level. So currently, we can't really estimate the prevalence of antimicrobial resistance in bloodstream infection. But this survey, which will be supported by WHO, it will help us to really estimate the prevalence of AMR, and this should really also help the clinician to update the treatment guidelines, depends on the data that will be generated. So we do have also other initiative of Fleming funds. We have Fleming Fund, which is a country grant, and it is now supporting some of the laboratory to strengthen their capacity to perform some of the bacteriological tests, including culture and antimicrobial susceptibility testing, actually it's a sensitivity and resistance. So we have also ICAS grant. ICAS, it's an international center on antimicrobial resistance solutions. This is a center from Denmark, which which is now supporting country to implement some of the AMS program for surgical antimicrobial prophylaxis in healthcare settings here in Rwanda. So we do have also pandemic fund through strengthening pandemic preparedness and response in One Health approach. So this pandemic fund does have also some of the funding to support antimicrobial resistance, surveillance, and stewardship. So all these are really some of the projects that we do have. There are opportunities we do have to help us implement, to help us really achieve to the target in regard to the National Action Plan. So with the contribution of the audience that we do have here, with the contribution of our colleagues, partners, actually we are confident that all these interventions will not be implemented at 34% as previously, but we are aiming to implement it even at 100%. If not possible, we can even achieve to 90%. Then, after these 4 to 5 years, we shall then try to go into other initiative or try to see how we can maybe sustain the interventions that will be achieved. So thank you so much for your attention, and we are looking forward to keep working with you to implement this initiative. Thank you.
Thank you very much. Thank you very much, Dr. Misbah Gashegu, the National Antimicrobial Resistance Focal Person of the Rwanda Biomedical Center, the Ministry of Health. He has highlighted the component of the National Action Plan 2, and the various opportunities are there. So please, let's ensure we network with him as expected. He has identified with us all that we are requested to do in terms of scaling up all the necessary levels of intervention. So we are delighted and very happy that you're able to make up in your participation, as we have been in touch since the National Antimicrobial Conference was held last year, and you promised that whenever this is to be held, you promise to be available. So that is the information. The copies are available. So we'll be glad that the e-copy that is signed will be shared with us accordingly for us to be able to have further interaction with the framework, and then be able to assist where necessary. So it's my pleasure to invite our panelists for the first panel discussion session on efforts on monitoring antimicrobial resistance in Rwanda. So join me to welcome our Prof, Professor Theogene. Please, can you please give a round of applause? To join him is Dr. Misbah Gashegu once again. An applause for him as well. Again, Dr. Misbah Gashegu. We have RAB representative. Thank you very much. We also have rep from RBC. We will be glad to have Dr. Nyoega Amayi join the session. And though this is served as an impromptu, but he has been an educator for several years in the medical and health sciences. We'll be glad to have Professor Ezra Agu into our midst. Can you please give him a round of applause? Protocol, please bring Professor Ezra onto the podium. Please, can we please keep clapping? Yes. It's an impromptu, but Prof is up to the task anytime. The experiences are there, and I will be glad that they are shared. So, can we Can we please add the mic shared with this? Thank you very much, sir. So the session is just going to be for about 30, 40 minutes. Then once it's completed, we'll now have Dr. Ju to give us the reports about the main Pfizer activity, the project activity as it is. So we'll start with our prof, Professor Tioji. Can you please tell us in 1 minute efforts that are being used, the effort being made in managing AMR in the country? Thank you very much, sir.
Thank you so much. I think I can start by saying this is a burden. It is even more pressing than HIV and cancer and whatever, because it can kill so more people than those conditions. But as far as Rwanda is concerned, we can say that we are still at the beginning, because efforts have maybe started by 2019, if I can say so. And at the level of the hospitals, there was almost no activity in terms of surveillance of antimicrobial resistance, yet it was a reality. Because the very first screening that had been conducted at Chub, for example, in 2017 or something alike, have shown that the carriage of multi-drug resistance among admitted patients was as high as around 60%. And at the discharge of the hospital, almost 70% had the multi-drug resistance bacteria, which means that in the community, the problem was already there. And it is not surprising given the patterns of antimicrobial resistance spreading within the communities. What have been done so far at the level of hospital? We have, first of all, tried to put in place some guiding principles. We have written a guideline for the empirical treatment of commonly found in our hospitals, community-acquired infections, which has been published in 2019. Then from that, we started monitoring the compliance with those guiding principles. But beside that, IPC principle, this is the cornerstone of all the efforts that we can make for antimicrobial resistant prevention. IPC principles, or IPC in general, has been strengthened at national level, but also at hospital level, not only for the hand washing, which is the cornerstone of the IPC, but also monitoring of those infections, hospital-acquired infections, for instances, which is almost on a monthly basis in our different department and services, at least at Shube and any other referral hospital. That is what I can say, but nowadays we are now revising, we have already revisited our guideline to try to accommodate what we call aware classification, access, watch, and reserve, so that we can preserve some antibiotics that can be useful for treatment of those high resistant microorganisms. Because as you know, developing resistance can take a month, but finding a new antibiotics can take more than 100 times than the development of resistance. That is what I can say. Maybe later on I can comment if needed. Thank you.
Looking at, now we are here, the same question still, but looking from your perspective as a RAP person bringing in the environment, agriculture, and the likes, what is your perspective about effort in reducing AMR?
Thank you. My name is Vestine Musanaire. I am working Rwanda Agriculture and Animal Resource Development as a veterinary laboratory manager and microbiologist. I have I'm working on IMR from 2007 when we were in RARDA, if some of us you know. And I have some experience on IMR in agriculture and animal, especially in animal sector. You should know that we are member of the technical working group on IMR, and I'm also focal point for RAB IMR. So we participated in most of those documents they presented. We participated in developing of NAP and other important documents Dr. Kasheku mentioned. But on Rwanda Agriculture Board, we started some activities to implement a national antimicrobial resistance national action plan. Even if we have some challenges, when we started, we didn't have guidelines. Most of guidelines was not developed. But last year, with the partnership with FAO, we developed some SOPs, and there are other studies which are ongoing to have a good and baseline or data on IMR in animal health sector. And we should know also that from in the past we used to work to perform antimicrobial resistance testing, but we don't have on our structure. We don't have any program on IMR in animal health sector. But to treat animals, we base on laboratory results, but the challenge is the farmers, they don't have a habit to use laboratories. But we have experience on IMR testing, and we are improving from the time we joined the technical working group. We have improved on IMR testing. And last week we started a pilot study on poultry from chicken, fecal chicken, meat chicken, and we have data from that pilot study. And we are planning that we continue in May to make a big sample size to have that baseline on antimicrobial resistance for E. coli and Salmonella from poultry industry. And we have a plan to continue developing guidelines and training our people on how testing IMR and how to use antimicrobial. Not good to use of antimicrobials, and we think that we're still working on other activities as they are stated in the National Action Plan, and we hope that we will have more support. When we look on the challenges we have up to now, we still hope that we will have more support to implement more activity on IMR. Thank you.
Thank you very much, ma'am. So Dr. Noega Amai, still the same. We know how active you are, so just from your perspective as now you wear both cap as an academic and as well as a researcher, and now in an implementing agency. So where are we?
Okay, thank you, Dr. Top. Towards controlling MR, a lot has been done. Yeah, I can start from the documents as Gasheg was presenting. It's like our Bible, the National Action Plan, number 1 and number 2. So that was like our Bible to lead us through the implementation of activities to deal with MR. Also, you can talk about MR without testing. We used to have like only 6 laboratories that are capable of doing bacteriology. Now we have increased those laboratories to 13. We are in the plan of even increasing more. So we are also supporting in the One Health approach, also lab in the One Health approach to have, they only have 1 lab doing bacteriology. So there's a plan to have at least 5 laboratories, 1 in each province to test, to do bacteriology and AST. So that's a plan that is already being implemented. Also, surveillance. Although it is not well streamlined, but we have done surveillance of some of the pathogens like E. coli, Staph aureus. There are some works that have been done, not on a regular basis as the real surveillance, but some work have been done. Also, training. With the support from WHO, through the project called the NHLS, National Health Lab Service, we did also training of around 250 laboratory technicians on bacteriology and interpretation of the AST results, antimicrobial susceptibility testing. So we trained them. Now we are even distributing, we distributed the basics equipment and the reagents for doing bacteriology. So laboratories, I think if you follow, hospitals like Ruhengeri, Gihundwe, they are now doing bacteriology. So it is the initial phases, but we hope that this will give us a picture of the country on how MR is. The 6 laboratories that I mentioned were not evenly distributed. 4 of them were in Kigali, only Sehashibe in the south. So we could not say we have even data on antimicrobial resistance. So increasing the number of laboratories that are testing will help to control the MR. Also, we do research. Fortunately, we have some presentations, although there are not many during this symposium, but some work, research on antimicrobial resistance, some of the pathogens that are not maybe commonly, routinely checked in the hospitals. Such kind of work show how MR is broad. You can go beyond the routine and show the level of the resistance, focusing on the priority pathogen by the WHO. Another one, although the Prof. Theogene also mentioned about it, it's to like optimize the antimicrobial use, because one of the drivers of MR is misusing antimicrobials through irrational prescription. So with that aware classification that we are promoting through in different hospitals, it's good that some hospitals could have some antibiotics in the reserve category. So their use should be, it's like last option. Those meropenems, mepenems, those should be the last resort in case other antibiotics have not worked. But sometimes you may say, if we don't test enough, that's where I start. Some hospitals, there's a research that we did at King Faiso. When we were doing interviews with clinicians, they were telling us, if I meet a patient, I suppose that he has, he's from other hospitals where has been placed on antibiotics. So I don't need to go back to the AST and see what are working. So immediately they prescribe the broad spectrum antibiotics. So having those, the aware classification that is enforced in hospitals would at least help us to slow down the level of resistance. Thank you.
Thank you very much, sir. Prof. Ezra,
as a professor of microbiology and immunology with vast experience in medical education, can you please enlighten us more on the various initiatives, particularly in terms of human capacity development that can assist in managing AMR?
Thank you for allowing me to spot to say something in this kind of esteemed gathering. The first is policy. I went to Malawi for a training and I was feeling somehow. I walked across to a place I wanted to buy some antibiotics. They told me you cannot get it. I told them I know what I'm looking for. I'm a professor. I said, it doesn't matter. You cannot get it. Go and get prescription. And those prescription, a doctor plus registration number who is gazetted, so that if there's any problem, we will know who is accountable. I looked around. That time I was in Uganda. So if, allow me to say small country, if a small country like Malawi can be so strict, then, so that is the first point, strict implementation of policy. The rules is what controls people here in Rwanda. That is the first thing we learned when we came here. So they are strict in rules. When they pass a rule, that rule is followed to the letter. So I would recommend policy on antimicrobial usage. Then the second is research. You will see that a lot of announcements and let me say noise about antimicrobial resistance may not be resistance. It may be reinfection. Reinfection. About 40 to 50% of reported treatment failure associated to resistance can be reinfection. So ground research directed to separate reinfection from resistance is strongly needed. Then the second part of research is my own personal interest, escape pathogens. I am very interested in escape pathogens because the escape pathogens are the cabals, what I call bacteria cabals that are refusing to let people go when they come to the hospital for admission. They don't allow you treat again and again and again. So we are now looking at the research on why are they keeping people, we call it prolonged hospital stay. The escape pathogen prolonged hospital stay, Acinetobacter, Klebsiella, and Proteus, and also the Pseudomonas and so on. So we are looking into it and we are leading the research on it. Then the second aspect of research, we call them superbugs. So it started with superbugs, multifactorial resistance. Sometimes you say multi-drug resistance, and but this one is conventionally resistant to everything. Everything. They have closed their doors, to human treatment, so that you can see that the research that you're going to be doing has to do with assay of body fluids, trying to recalibrate the dosage that is already known. Then the next I will talk about is what we already know very well, capacity building. The Team Europe initiative on mass access to vaccine, drugs, and other related medicine, TailMav initiative, is a project which is ongoing, and as the co-PI of that project here in Rwanda, the initiative was, in as much as there are other access to medicine, the initiative also took into consideration resistance, whereby we added infectious disease and experimental animal, because experimental animal master's degree is going to take care of preclinical trial. Although there is master's in clinical trial, there is experimental animal, experimental medicine takes care of preclinical trials. so that we train experts in preclinical trial and also in clinical trial. All is to manage and to manage the concentration and the use of medicines and antibiotics. The next thing I would like to talk about is a kind of stakeholders. The key players have not taken time to incorporate the stakeholders that are supposed to be in charge of antimicrobial resistance. The stakeholders are not just the prescribers, the users and the administrators, the nurses. I was looking for a representative from the Nursing Council, a representative from the Medical Council. Of course, microbiologists are here, and the pharmacologists, we have experts here, and so on. People and the users. I don't know how to select the user. Somebody who has been admitted to the hospital and it's not easy for him to be released. It's like has faced some challenges. Then there has to be some kind of meeting during this kind of symposium. Thank you for the organization, so that everybody, if I am treated and it didn't go, and again, then we'll be able to share ideas, so that when the doctor prescribes correctly, for instance, the pharmacist, the clinical pharmacist prescribe correctly, and in order to add, clinical pharmacy and therapeutics is another master's we added to be in charge of, to train experts that will help in charge of prescription and the proper administration and dispensing of medicine. Clinical pharmacy and therapeutics is one of the masters this project is sponsoring. So if there could be a kind of meeting, like a focus group discussion or something like that regularly, then it is going to give administrators and healthcare providers the kind of idea that will help them manage very well. Otherwise, I think Rwanda is in the forefront in making sure that they take the bull by the horn. And that is why all of us, we are here to make sure that not only are we advocates, we are also helping in implementation. Thank you.
Thank you very much, sir. Provost has emphasized the need for stronger adherence to stipulated policy, as well as strong emphasis on research. So may I ask Dr. Gashegu to please confirm what the Rwandan Biomedical Center is currently doing in tracking the AMR countrywide now.
Thank you, Dr. Taufik. So actually all the initiative or all the interventions that have been highlighted by colleagues here at the panel are some of the initiative of the country. It's not just RBC or Rwanda Biomedical Center which is doing all these initiatives. We are just coordinating what our key players are doing. So in regard, actually, if I can maybe tell you a story, in 2020, we visited some of the biggest hospitals here in Rwanda, where we have been trying to really collect some of the data that have been generated previously. So, and we've met one of the clinicians, telling them that we are trying to collect some AMR data, and an experienced clinician was really asking, what is AMR? I don't really understand AMR. Whether he was an experienced clinician for the last 10 years. So knowing this or not knowing this was not really a big deal, but what was really followed after having some knowledge on this antimicrobial resistance. So now we are in 2025, but this hospital is among the advanced hospitals to tackle or to implement interventions to fight against antimicrobial resistance. So this was really challenging to start educating IMR issues and related issues. And I have also visited, I've also attended some of the conferences at regional level. You know, Rwanda, we had some of the opportunities to tackle IMR later than other East African countries or Southern African countries. But Rwanda was invited to some of the conferences, and I was there as the focal point on antimicrobial resistance in Rwanda. And they have invited me to go and speak what Rwanda has done in regard to antimicrobial resistance. I was like, what am I going to say? Whether we had only the document. Of course, having document is a big step, but having document, it's not really enough. So we need to really move from document to actions. So that's what we are now doing. So during that period of time, I really presented only that we do have policy, we do have strategic plans, we do have national action, but if we are being invited to some of the conference at regional level, even at global level, we are really confident on the interventions that have been highlighted by the panelists here. So we are glad that we have been really having some of the interventions. And the most important, if we can go back to the question from Taufik, we really try to select the sentinel site because we should not have been really implementing the interventions to all the facilities at the same time. So we are working from sentinel site. We are working at the sentinel site level. So we try to select 17 sentinel sites across the country, whether we have 12 sentinel sites in human health and 5 sentinel sites in animal health sector. So both sectors have to really try to implement some of the interventions in environmental aspect, including hospitals as well as veterinary facilities. We are trying to incorporate environmental initiative into all those sectors so that we can try to generate data, AMR data, across sectors in One Health approach. So from having those sentinel sites, we then developed the national surveillance system. So a national surveillance system which should be integrated to the existing system at facility level. That's what this is really the way we are working, and we are now, as I just mentioned, CHUB has been considered as an example of other facilities which should really have the same system so that at national level we can be able to really integrate the national surveillance system with the existing facility or existing patient management system. And in regard to surveillance, of course, testing is very critical, and I think my colleague Noel has just mentioned the progress that has been made in regard to testing, and also without knowledgeable personnel, we can't do nothing. We can do nothing. So we have been trying to really train the professionals at facility level on surveillance as well as stewardship. So now, as of now, at those sentinel sites, we do have trained personnel on antimicrobial resistance as well as on antimicrobial stewardship. That's why each and every facility or sentinel site in human health sector, they have already established the stewardship committee. And those stewardship committee are the one who are driving the stewardship activities in healthcare settings. So now we are planning also to initiate the stewardship initiative into the animal health sector. So these will helping us to really achieve to the target that we have already set. So also, we can't really forget the academia. So as professors and doctors here just mentioned, there are some of the initiative to really incorporate a microbiology field into academia, where you can compare the number of or the proportion of microbiologists in academia now compared to in the last 10 years. It's quite different. So it might have been really multiplied by even 4. So this is among the initiative that the country is really doing to tackle antimicrobial resistance. Thank you.
Thank you very much. On the final note, I would like to start from Prof to enlighten us on the community-led awareness initiative that can assist to improve the level of education. So that's the same question for everyone, and then we'll conclude this session.
Thank you. Thank you very much. I think you read my mind. Because that was the lacking piece. Oh, there are so many other pieces, but the community should be aware. Not only because they can get all the antibiotics or antimicrobials from the private pharmacies. That is why I first of all concur with my colleague. We have to have strong regulations that govern the prescription and dispensing of antimicrobials. And then once this is empowered or implemented, we need to go to the community and explain what is the problem with the antimicrobial resistance. Because as I did mention, this can kill more people than AIDS or cancers within 5 or 10 years. So we need to work hard enough from now if we don't want to lose our people. Then since the community is probably close to the politician than ours, we need to try to find a way to convince the policymakers in a language that they can understand. From our researchers, if we do research, we don't just report prevalence of antimicrobial resistance and so on, but also we need to relate on impact on the outcome of the patient, but also on the cost effectiveness, because that is the only language the policymakers and the politicians can understand quite easily. Thank you so much.
Thank you very much, Prof. Dr. Gashegu?
Thank you. Going to the community, actually, awareness is the most important aspect to really educate the community, and the reason why awareness has been really mentioned as the strategic objective number 1. You can't really fight what you don't know. So we need to really find a way of educating our community in their actually making sure that they really understand IMR. If you can go to at village level and mentioning antimicrobial resistance, I'm not sure that everyone will understand what you mean. So we need to find a way of really giving them evidence of this threat, this silent killer, as DG Sashibe mentions in his opening remarks. Actually, he said that it's a silent killer. How does this antimicrobial resistance, being a silent killer, and you give them examples. We do have some of the patients who are really staying longer and longer in the hospitals. So you need to explain to them, you need to explain to the community, why do all those patients are really staying longer in the hospital? And you might find some of the patients who are at hospital all the time, every day. Every day they are really living at the hospital. Why? Because there is no treatment, there is no really drug that can really treat their pathogens. So it means that drugs have been resistant to the pathogens that are really hidden into their body. That's why those patients are really there. And you need to really educate community, how can we really prevent this antimicrobial resistance? Of course, after training them, because of course we have been started by the clinicians, the nurses, pharmacists, but now it is the time to go to the community, educate them. Then once we really educate those people through all these WOW week, as we mentioned, WHO has been really setting up in November as a World Antimicrobial Awareness Week, whereby we really stand up and educate our people about antimicrobial resistance. Then once the community is aware about the IMR, we then go to the regulations. Rwanda FDA and other regulatory body try to set some of the regulations as per the colleagues, the developed countries, whereby you can't really buy antibiotic however you want. So you need to have a prescriptions practice. So all these are really the process. We are still trying to educate, but we hope with this National Action Plan 2.0, we shall be having really a progress in regard to the good practice on prescription practices. Thank you.
Thank you, sir. Dr. Vestine?
In a animal health sector,
yes.
Let me telling you that we have activities in animal health sector which are not similar to other plant sector or crop sector, and I belong to the animal health sector. What I am going to tell you is on animal health sector. On our side, we are working with Rwanda Veterinary Council of Doctors, and we started by training the veterinarians grouped into companies. Okay. Yeah, we are on that step to train them on IMR, but we are still waiting for the document, the policy on antimicrobial stewardship in animal health sector. Okay. But we are still training training veterinarian lab technician on how performing the IMR testing, and we are advocating on our policymakers, because when we look on our sector, we found that there is a need of strong advocacy through the policy makers, because there is no structure on IMR in our sector, but we are still working on it. Then we organized some awareness campaign through Farmers Association. In animal health sector, we have categories of farmers. We have farmers who have large animals, cattle. We have association for small ruminants, goats, sheep, pig. We have the association of farmers who have chicken. We have many associations which also make our sector a big sector on IMR surveillance. We need more support and more effort because we will have many products to work on it. It is not like in human. We started with cattle and poultry, but we should go even for aquaculture, for honey, and for goats, sheep, pig. We have a big work to do, but we will still advocate for more support, more organization to give a visible improvement. Thank you.
You're welcome. Thank you very much. Your sector is very key, and all the support that are needed will be provided. We are all listening we have listened to the challenges, and we hope that these resolutions will come very soon. Dr. Noel.
Okay, thank you. Actually, the community really plays a big role. If we can see the antimicrobial resistance at clinical settings, we can predict or imagine what is in the community, because it's a reflection of what is in the community. So what do we do, or what we have to do, it's trainings or awareness campaigns. I remember since 2020, we are organizing in November, from 18th to 24 November, we are organizing the World Antimicrobial Resistance Awareness Week. It used to be World Antimicrobial Awareness Week. Then to make it understandable, they added the resistance. So since 2020, we are doing those awareness campaigns. We go to the radios, television, we go to schools to teach or to educate people on antimicrobial resistance. I remember in 2022, I was with Dr. Jibril at the Radio Huye. When we were educating the community, we go around the different radios throughout the country to train people, to give them the basics of antimicrobial resistance, how it is a problem, and how to tackle it. A challenge, a task that I'm giving to all of you or all of us is to develop our documents in Kinyarwanda, our mother tongue. I remember when we were trying to translate antimicrobial resistance, ubudahangarwa bw'udukoko ku miti. Someone was challenging me, ubudahangarwa, kind of immunity. So we need to develop our documents in our mother tongue so that the lay person can understand what is antimicrobial resistance and it will easily assimilate the concepts. Also, it's our tasks in clinical settings, clinicians, pharmacists. It has been, let me call it a bad practice, maybe because we don't have many doctors, or the pharmacists, they are maybe in a business, they want to serve many people. But when you give a prescription to a patient, it's good that you give a short notice on good conditions or how he should take that and those antimicrobials. In case he doesn't or she doesn't finish the prescription, what will happen? So he or the patient goes back having in mind what are the consequences of not completing the dosage. The pharmacists, you see, they give you, they dispense the drugs, and sometimes they may not tell you, take at this period, don't miss. So it's like we have to put much effort into educating the community, not only during the WOW, but in our respective roles as clinicians, as pharmacists, as nurses. So wherever we are, we can do something. Even our colleagues, you go back, you can inform your colleagues what you learned or how you can do it. Another aspect that Prophet Eugene mentioned, it's about the cost. If you tell them, if you don't take correctly those antimicrobials, there will be a burden on you in terms of cost. If you are not treated, let's say, by amoxicillin, which is 1,000, you need maybe amoxiclav, which is 7,000. So if you explain to him in terms of money, that if he doesn't pay attention, he will pay more, I think he may also somehow be persuaded to adhere to the prescription. Also, Gasheg also mentioned about the long hospitalization. In case you don't take your antibiotics, you may need to go to the hospital, you will spend weeks there, and you will not be able to work and benefit from your daily routine. Another aspect, although it is not directly linked, but it is associated, is to improve the wash, water sanitation and hygiene. Because above 70% of the infections can be prevented with those simple measures. So if we focus also on wash, we will prevent the infection and we will prevent the use of antimicrobials. I may end with recently published the paper where we had Prof. Ezra was mentioning about multi-drug. No, we have even a pan drug, a pathogen that is resistant to all antibiotics you can test. We recently published the paper that it doesn't, those cases, they are not from outside. Even in the country, we have such cases. So we should make them known, make people that the issue is there so that they can take responsibility to find solutions or to contribute to finding solutions.
Thank you very much, sir. Professor Ezra, on a final note.
Yeah, thank you. The first point I want to make about community is self-medication and drivers of self-medication. Self-medication and drivers of self-medication. Yeah, there is a lot of education. There's a lot of awareness. But self-medication, who among us, when we are sick, we think of a doctor? The percentage is very low. And then, who among us, even when we think of medication, go to the right personnel, either a nurse or a pharmacist, for an answer? It is still very low. So the campaign for us that are research against self-medication and the drivers of self-medication, it should be brought down. That's the first point I want to make. Then the second point I want to make is source of information. Source of information is related to hesitancy and acceptance. Hesitancy against medication and acceptance. Which medication will you accept? If you were taking, for instance, chlorophanicol, which is no longer in use, if you were taking ampicillin, all of a sudden, somebody tell you that it is an ampiclog that is being used now. Which source do we believe? Is it the radio? Is it the television? Must we see the director of the hospital or the director of the RBC before we believe that? So we should find out from the community and the users what makes them convinced that this medication, because like doctor have said, it is the issue of sublethal dose that helps microorganisms get acquainted to what we are doing, and then they will now mount resistance and shut us off in their community. So self-medication and drivers of self-medication, number one. Number two, source of information and means of information. He talked about language. If we communicate with the right language from the right source, I don't know which one is the right source. We have done some research in the past. Some say it is television, others say it is radio, and apart from radio, there are thousands of radios. Which one is official? There is an announcement you make now. In the next 2 months, people will not hear it. But there's an announcement in a particular means, media, or other radio, I don't know which one. Within 1 hour, the whole country will hear it. So this is what we awareness campaigners should find out, so that what media should we use. Then jingles work. I don't know, we have done that and it works. Jingles. People, even in Uganda where I have been, even here, a Boda man has his phone in his ears. He has no time to sit in the house to listen to news, but there is a jingle that will ring in his head, and he makes decision. By the time he goes to the next station or next bus stop, he is already advising people on the latest information, so that it is, the jingles works, and it is also probably affordable to getting the right information in the right language to the right people at the grassroots. It works a lot. And when we do that, I think we move forward. Thank you.
Thank you very much. Please, a round of applause for our panelists. Thank you very much. So we have been educated on the various efforts that have been made to be able to tackle AMR in the country. And resolutions have also been proposed that can assist us to scale it down, while also identifying numerous opportunities that we have ahead. So I would like to invite Dr. For the question and answer, in brief, before we invite Dr. Jules, is Dr. Joyce Kamanzi to lead us in the question and answer from the audience. Those that are online, please feel free to share your thoughts. We'll be able to manage from here. Please, can I have the mic, Dr. Thank you.
Is there anyone who has a question? Thank you.
You identify your name and then your institution. Thank you.
Thank you very much. I am Tolesa from Department of Biochemistry, Molecular Biology and Genetics, School of Medicine and Pharmacy, UR. Thank you very much for your speech. Yeah, most of the time, it is easy to plan together, but the problem is to implement together. And my question is just to RBC, MOH, RAB, and the Ministry of Environment. How far are you in working together, especially in eradication of AMR through tracking the real case and identifying the contributing factors, which in other way to implement One Health approach? We know that thanks to this OH approach that contribute a lot, especially for AMR, because environment contributes for animal contribute for human, animal contribute for environment again, so that it is a kind of vicious circle which can contribute for the wellness of human beings. So how far are you in reporting, in identifying, in tracking the case? Thank you.
Thank you.
I was wondering if we are going to answer the question directly or have to collect all the questions.
We can start with 3.
Okay.
3 after 3 responses. Thank you.
Thank you for the good presentation and the panelists for the discussion. My question goes to Dr. Gashego. You told about the NAP1 and how you did NAP2. Wondering what was the outcome of NAP1 that led to NAP2? What was the outcome, the challenges you had in NAP1 that you want to tackling in NAP2? And how are you going to measure the outcome of this NAP2? Thank you.
Another question, I think. Maybe we can go ahead to answer the 2 questions. The one from Teresa.
Let's have just one
I
more.
think.
Let's have one more.
Okay.
Yes.
Dr. Jules has a question.
Thank you very much. My name is Alliance Ishimwe. I am a pharmacist. I work for Rwanda Medical Supply Limited. I had a few questions. My first question was on how the government or the university or whoever is doing researches is working with dispensing pharmacies. I did not hear a specific intervention about them, and yet they're the ones in the community serving these antibiotics. I would like to understand what exactly you're doing with them. And my second question goes to everyone on the panel, because most of these interventions are here, they're about training and going to communities. But I want to understand what happens after this. How are you going to be able to sustain these interventions within the communities after the funding, after everything? Like, is there a sustainability plan for what you're doing? And I've seen Rwanda FDA on the list of people who are part of the technical working group and the steering committee. But it makes me wonder why pharmacists are still dispensing antibiotics, even though Rwanda FDA as a regulatory entity is there to survey that as well. Is there a gap or something we are missing? Thank you very much.
Okay, thank you. A bit of moderation. We still have 2 other sessions focusing on AMS. So this session is particular to AMR. So let's limit all our questions to that. And then let's have all the feedback and then a single response before we go to the next session. Thank you. So the resource person are taking notes. So let's have all the questions and then we'll respond accordingly.
Okay.
But let's make it brief.
Thank you. My name is Dr. Jamari Vianney Kajimangabo, Director General of Kigeme District Hospital. Mine is not a question, just is a confirmation to show how antibiotic resistance, how it is prevalent. Recently we organized, it's like a project, quality improvement project, emphasizing on microscopic hygiene. We used to have surgical site infection among post-cesarean section women, and we did a number of interventions. There was no response. We said, let us take pass for each surgical site infection and see which germ are we fighting with. Surprisingly, the germ we found was Klebsiella multiresistance to a large number of antibiotics. And then the campaign was to reduce antibiotic prescription among post-cesarean section women and to sensitize doctors that the cesarean section is a clean surgery. There is no need of adding antibiotics. And even in neonatology, we had the same case, but the resistance was not coming from neonatology. We are raising resistant germ in maternity, and then we are transferring those resistant germ in neonatology. And we focus intervention, number of intervention we used to focus in neonatology, but which is not the case. We take some hemoculture, also sent to National Laboratory Reference. And then for those neonatal cases, we found the same case, multi-resistant, the Klebsiella drug resistant. And then the effort was put in maternity. Next month, we didn't record any case of surgical site infection. Among 100 cesarean section performed, we recorded only 1 through reducing antibiotics and the rough cleaning in maternity and promoting the hygiene among all women, ensuring that every woman had an hygienic paper. Hand washing facility closer to their toilet room, even to their wards. So the antimicrobial resistance is not a single problem to CHIV and other big teaching hospital. We have a lot. For those germs that we found, the Klebsiella we found was resistant resistance even to imipenem. And we don't have them. It's like a close resistance. So the problem is so big. And lastly, to confirm the importance of One Health, we recorded another case of community-acquired Klebsiella. We thought it has been raised, the antibiotic resistance has been acquired through animal products or any other kind of source of resistance that may have. So, to conclude, antibiotic resistance is a very big problem, and we need to be in action, all of us. Thank you.
Thank you very much, sir. We would like to close maybe after this so that we have the privilege to get the responses. All other questions will be entertained in the next session because of our time.
Thank you very much. My name is Emmanuel Kundukundwe. I'm a student from University of Rwanda in Biomedical Laboratory Sciences, year 4. First of all, thank you for this interesting panel discussion. And I have a concern about community awareness. Last year in January, I had the privilege of delivering a radio talk on behalf of Association of Rwanda Biomedical Laboratory Students about blood infection. And one of the people who called the radio pointed out something very interesting. This is about the use of antiretroviral drugs and veterinary medicine drugs in treating and closing open wounds. Now, in their own perspective, these drugs and how they're using it in closing and treating wounds, it's quite effective, and these wounds are treated perfectly in their own perspective. But we as scientists, we know better, because this is mostly one of the ways antimicrobial resistance, that's where it comes from. Now, my question is, how are we, or how are you going to convince these people that the use of these drugs in a wrong way in treating wounds create antimicrobial resistances, especially in bacteria, like the DG from Sashibe pointed out, mainly bacteria that infect wounds like E. coli, Klebsiella, Staph aureus. They are resistant to many of the drugs, but the people, they use those wrong drugs in treating wounds, and they are treated perfectly, but it creates the resistance. How are you going to convince them? How are you going to change their perspective, and how are you going to change their understanding if they get the results they're hoping for? Thank you.
Thank you very much. So now the responses.
Please,
for now.
Only one.
Okay, yes, okay.
Yeah, thank you so much. My name is Jerome Sanzimana. I'm coming from Sashibe in the IP service, Infection Prevention and Control Service. So I'd like to appreciate the presentation and the panelists, what they have said. And I would like to ask a question about this action plan on EMALA to Dr. Kashegu. So you have said about this action plan, about the use of antibiotics, but when we see and you go beyond to the antibiotics, we see also other antimicrobials. So among those antimicrobials, we see also disinfectant. I say this because in the IPC, for us we say that is a pillar, as Prof. Theogene was saying, in a cleaning or the contamination of reusable materials at the health settings. So I'd like to ask if really on this action plan has also thought about this antimicrobials disinfectant, because if they are not used rationally, so the microbial or resistance of some bacteria will be there. And we see that those reusable material
are still serving other patients. If those materials are not well decontaminated by this disinfectant, they may transmit those resistant bacteria or microorganisms. I would like to know if really this rational use of antimicrobials such as disinfectant has been thought on it and has been put also on this action plan. Thank you so much.
Thank you very much. So now we have the responses. So in no particular order, perhaps we start from Prof. Do you have any, okay, in terms of the implementation? Yes. Thank you, sir.
Thank you so much. I think in terms of community awareness, we don't, of course, we have to play a key role. But as far as the community is concerned, as I did mention, we need to involve those who are close to the community. As Rwanda, we know who is really close to the community. We have the opinion leaders within the community and whose word is very well listened than ours. And we have the community health workers that are playing a key role in the community in terms of the health, and also we have the local government. If you want to reach the community more in efficient manner, we need to involve those key players within the community. That is why I did mention, and my colleague Noel have already mentioned it, we need to find a way to have a message that they can understand, that they want to understand. For the community, they don't want to understand as the Klebsiella pneumoniae is resistant to meropenem. It doesn't mean anything. But if you say, if we do not do anything, if we don't stop this trend of the emergence of resistant bacteria, so many people will die. And we give some examples. Or cost of the treatment can be doubled or higher. Or you can even, after the hospital discharge, your life is no longer going to be like it was. The quality of life post-hospital discharge. Those are terms or the messages that the community can understand. And we can use those opinion leaders, community health workers, and so on. So coming back to the last question, disinfection, IPC, I do agree it's a key. Even the case for cesarean sections, I think the pre-op preparation for C-section, if we use a proper cleaning, either with soap or chlorhexidine, we can prevent more than 90% of those surgical site infections. Thank you so much.
Thank you, sir. Yes.
Thank you, Prof, for responding to the questions. Mine, I'm gonna maybe tackle to some of the questions that have been asked to the National Action Plan. So, and also question from Dr. Teresa. He has asked about the status of implementation. So it is true that planning together, it's easier than implementing. So sometimes we do face challenges to implement together, but in Rwanda, as we just mentioned, the policy, the One Health policy, which is really clear and guiding us how we can really implement together. So all the initiatives that have mentioned earlier, there have been really achieved achieved together across sector. So if I can maybe answer the question, how far we are with working together, so I can respond, we are somewhere, but we are still we are still working together to reach even far from where we are. So working together, it is very easy in One Health approach here in Rwanda because of level of understanding of the leadership across sector. So this is what is really helping us to work together to achieve to all the initiative that has been mentioned that I can't really repeat again. So if I can go to the question from the representative of Pfizer, unfortunately he's outside, but he asked about the challenges. He might be the one maybe to feel or to address some of the challenges that should be highlighted here. But we are glad that we are together with him, and we will be having opportunity to even keep networking with him and discuss how we can maybe address all the challenges that have been that we have been facing in the NAP 1.0. The first challenge was about the funding. Actually, NAP 1.0 was not really fully funded. That's why it has been implemented at 34%. So all those, the funding that have been used, they were reallocated from other interventions. But now we are glad that we do have some of the funders, sponsors who are really supporting some of the initiative. And also we had some of the differences between NAP 1.0 and NAP 1.2, whereby we didn't have really a clear national group plan with a clear monitoring the evaluation framework, which is now already it has this monitoring the evaluation framework. Also, the costing matrix or the budget that has been highlighted into NAP 1.0. Actually, all these were really some of the gaps that have been highlighted into NAP 1.0, which have been addressed to the NAP 2.0. And we are really confident that with the opportunities that we presented here, so we'll be reaching even far from the NAP 1.0. So in regard to the question from our colleague from IPC team of Seashwibe, so for your information, we do have a strategic objective number 3, which is talking much more about rational use of antimicrobials. So it is really a strategic objective itself. So don't worry about that. So once the NAP is published on the website, you will look at all the interventions in regard to rational use of antimicrobials. Over. Thank you.
Thank you, sir. Dr.
I am going to talk on how are we convincing people on bad practice of drugs. I think in animal health sector we have a big work, we have a big way to go, but I think it is the activity we have. We cannot say that we will have a time we will say it is enough, but we are on starting point, and we will continue awareness and teaching people. We will not stop telling people to use good practice on antimicrobial antimicrobials use. Then I think with policies, with good policies and guidelines, if they are available, I think we will monitor them and continue training, teaching people. I don't believe that we will have a time we can say it is enough, but we should start and telling people. I know that that we will have improvement with time if we still increasing efforts.
Okay, thank you very much, Dr. Noel.
Okay, yeah, thank you. I may start with Dr. Tolesa. Yeah, although Gashegu has talked about it, but how far we are. Now, if you are increasing testing, already it's one step ahead. Before we had 6, now we have more than 12 hospitals that are doing bacteriology. Also in veterinary, laboratories are increasing from 1 to 6. So it's one step. For Dr. Ishimwe, okay, the outcome from NAP 1 to NAP 2 that can guide the NAP 2. Okay, first of all, like in research, they were limited the research, but now research is output is increasing. Even the master programs, as my colleagues have mentioned before, we have now like 2 masters in microbiology, 1 in infectious disease that will be starting soon. All those, it's like opportunities to get more data and how to improve the antimicrobial resistance issue. For Ishimwe, government working with the pharmacies that are dispensing still antibiotics, but without good interventions to solve that issue. We are with Denise from the National Pharmacy Council, and also with Gashegu. We have a platform where we discuss, and there are some trainings that are organized also for the community pharmacists and the organization, how they should dispense antibiotics based on prescription. So reduce the dispensing antibiotics without prescription. For the sustaining intervention after funding is over, yeah, it's what we are doing, homegrown solutions. Once hospitals have laboratories that can do bacteriology, what will be remaining is the normal routine of ordering things. So that will be incorporated into their CBHI, community, like the mutuelle. So if that is already incorporated, it means that the funds from the payment will be used for purchasing the other reagents for continuing this activity. For the community awareness from our males team, yeah, it's good that you mentioned it, and Vestine has mentioned that. There is even beyond that, some use even some drugs that are reserved for pigs because they promote so there is misuse of antimicrobials, and normally around 70% of antimicrobials are used in animals. So we should help the animal sector to solve the issue of misusing antimicrobials, because it's where, if also zoonotics, around 60% to 70% of the infections in humans are from animals. So we really need to tackle the issue of antimicrobial resistance in the animal sector if we want a better outcome in humans. Thank you.
Thank you very much, sir. Prof, in conclusion.
Okay, thank you. How do we convince the users of drugs to treat wounds that it transmits antimicrobial resistance? There is what we call, in science, there is what we call trans-kingdom transfer of resistance. It has been proved, and it is common. In trans-kingdom transfer of resistance, you will see that resistance reported in Rwanda about antibiotics that has never been used in this country. It has happened in Malawi, it has happened in other places. So if somebody used a medication for something else, the environment is like the pot, the cooking pot for resistance. And the environment which contains a lot of microorganisms, they may not be responsible for sending it to human beings, but they will be responsible for trans-kingdom transfer. That is to say, Staphylococcus can transfer resistance to Candida. That is Candida albicans. Candida albicans can transfer resistance to a bacteriophage. It is trans-kingdom transfer. It is there because when in the hospital we finish and then we pour our antibiotics solution, which we use to clean, disinfect into the environment, then another people from the agricultural sector, after immunizing, or they will also pour into the environment, and then the community also. So the environment is playing a prominent role in One Health. When those that are into One Health, a prominent role. It was previously neglected because they were thinking it was not important, but recently the role of environment as the cooking pot for antibiotic resistance is drawing many attention. Again, you might also wish to know that the latest, one of the latest technology in tracking antimicrobial resistance is a technology called phyllodynamics. A technology called phyllodynamics takes three approaches into one. Number one, phylogenetics analysis. Number two, evolutionary history. And number three, epidemiology. So phyllodynamic analysis is going to consider three things into one. Because as the question of origin and the transfer and the sustainability of resistance continue to increase, then scientists are also asking more questions and bringing more technologies. So phyllodynamics that will look at the same time, look at phylogenetic analysis, at the same time look at evolutionary background, evolutionary history of such, evolutionary analysis, and at the same time epidemiology. You can see modern technology, public health, and environmental aspect is being conjectured into one technology that provide more answer to solutions and questions being asked by not just the community people that suffers it, by the healthcare providers. So at that level, community people are going to benefit, and we move forward from there. Thank you.
Thank you very much, sir. Can you please give a round of applause to our panelists? So in closing, on behalf of the DG, we would like to appreciate you for the very insightful presentations, and we hope that we'll be able to work together in a more concerted effort at lowering the burden and improving on AMS. Before we go, Professor Dr. Theogene is a critical care expert, and is also the head of the Clinical Services Division of Shashube. A round of applause for Prof. Followed by him is the man of the day himself. Today is Dr. Gashegu's day, and, and as the director of One Health Unit of the Rwanda Biomedical Center, as well as the AMR focal person, we are delighted to have you here. A round of applause for him as well, too. We have Dr. Vestin Musa Naire. He's a microbiologist at the Rwanda Agricultural and Animal Resources Development Board, RAB. As well as our own, Dr. Joel Gamai is a microbiologist, as also the acting division manager at the National Reference Laboratory of the RBC, also a lecturer at the University of Rwanda College of Science and Technology. And finally is our own Professor Ezra Hagu. He's a professor of microbiology and immunology, School of Medicine and Pharmacy, University of Rwanda. On behalf of the DG, we thank you for coming. So we have a group photograph, and then you can take your leave. Thank you very much. Photographer. So while the photography is being on, I would like to call on Dr. Jules Ndoli for his presentation, sir, on behalf of the DG. On behalf of the DG, I'm inviting my prof, Dr. Jules Ndoli, for his presentation, while the Photographer, where is the photographer? Please, the panelists, could you please rise for photograph? Thank you very much. We are very happy and grateful. Thank you very much. Thank you. You can have your seat. While I invite Dr. Jules for his presentation. Immediately the presentation is concluded, I'll be having a break for lunch. So after the lunch is concluded, we'll be having the oral presentation 1. So I'm inviting all oral presenters that are here to please share their PPT via the email, should please do so now. We have 6 more outstanding out of 16. We have received 10. We need more of those. We need 6 persons that are here to share theirs. Please kindly do so via the email. Thank you. So Dr. Jewel will be speaking on capacity building on the implementation of the Antimicrobial Stewardship program, as well as antimicrobial surveillance at Chub. Thank you.
Thank you very much. Thank you, Dr. Taufik, distinguished guests, dear colleagues, dear students, good afternoon. And thank you again to join this symposium. With a great pleasure, in the next few minutes, my colleague Dr. Jibril and I will share with you the hospital journey in implementing the antimicrobial stewardship and antimicrobial resistance surveillance program in our hospital. So my name is Jules Ndoli, and I'm one of the members of the big team in the hospital involved in this project. And Dr. Jibril, here present, is the team lead of this program. So this is the outline. We'll talk about the project, the EMS status at CHUB, the baseline result that we got through this program, the EMS program implementation, the antibiotic resistance testing capacity in the hospital, the baseline result, and enhancement of anti-sensitivity tests in the hospital to improve the use of antibiotics in the hospital. Actually, this program started almost 7 years ago, around 2018, sorry. And we started this project with different partners. It's an opportunity to acknowledge their contribution. We have partners from Germany, and we work with them for the last 15 years in different programs. And for the first project called Combat EMR, Combat stands for Comprehensive Multi-Center Bioinformatics-Based Action to Tackle EMR Sub-Saharan Africa. So this project involved 5 countries: Rwanda, Kenya, Uganda, Ghana, and Ethiopia. So the idea behind was to see how we can share data from the lab and have an idea on the profile of the resistance in our respective facility. So the project in February 2020, we had a meeting in Ethiopia involving all partners to discuss how we can develop a tool, e-health tool, so that we can collect data and share between these countries so that we have an idea on the profile of resistance in our region. So we, to achieve this, we, apart from colleagues from Africa, we have colleagues from Charité Hospital in Berlin, and we come up with this e-tool where you can, any prescriber in the hospital can get access to data on antibiotic sensitivity, and this can help him or her even for empirical treatment to use the correct antibiotics while waiting for the result from microbiology. So this tool was developed and already in use in our hospital, meaning that from doctors in our hospital, they can get the right information through this platform and even empirically prescribe the right antibiotics. Once they have the result from the lab, they can adjust, escalate, or desescalate the treatment. So the platform is already in use. The main challenge is to have an interface between this tool and the electronic medical record that we use in our different hospitals. Because the ultimate goal is that we should have the whole picture in the country on the profile of antibiotic resistance so that we can improve the use of antibiotics. This implies, of course, that we have also the capacity at district hospital, the testing capacity, which is not there in most of hospitals. Once we have this capacity, we can have this interface with the electronic medical record so that we can share data. And the format used is the format used also at the national level, the DHIS2 database, so that we have the same format that can be used in all hospitals. And at the national level, they can have all the information in the country. Beyond the country, we can also have the information in the region. As you know, the EMR is a worldwide concern, so we need to work closely with other people, with other countries. So it's time for me to acknowledge the contribution of everyone, starting from the management of the hospital. As you can see, it's a multidisciplinary effort. We have medical doctors, we have pharmacists, we have lab scientists. Previous colleagues mentioned also the role of the community, the role of the private facilities, pharmacy, hospital, clinics. So we need really to join our effort to tackle this big concern as mentioned by the WHO. So we have the next part, the next part of my presentation. As I said, I would like to call Dr. Jibril to come forward for the data that we collected in the hospital. Thank you very much.
abantu bagufi akantu karankingirije ntimumbona neza ntabwo mumbona Thank you very much. Yes, as Dr. Shire was saying, this project and the activity of this project, capacity building on IMS and IMR, in fact, is the umbrella of this symposium. And we are happy that with the collaboration with whoever who contributed, we made it, and we are gathering here. So, yes, historically, and now we've been collaborating with the Charité, University of Berlin, to do surveillance, to do research, and to do intervention relative to antimicrobial stewardship in our hospital pertaining with them, but in this kind of cooperation that is combat. And one of the biggest achievement from our hospital is the development, customization, and implementation of this e-health tool. The e-health tool was implemented in our hospital. The hospital used it, gathered data, reported data, and then the data was reported to the Minister of Health, but also advocating to scale up the tool, to be used in other health facilities, while integrating it with electronic medical record used in Rwanda. As you can see on your presentation, the big challenge was this integration. The integration that was dictating the laboratory scientists to test and record data in two platforms. In fact, mitigating this challenge, it is straightforward, and then this tool can be used and get direct data from any testing laboratory to the national level. And as you can see, it was initiated through an international collaboration, and why not in the regional for comparative, and also worldwide to just publish our data and decide based on data. In fact, we need to do any intervention that is data driven, not because book says or someone is thinking, but data driven. So by now, the tool is being used for collecting aggregated data, but we need to get this real-time data from our respective electronic medical record. We thank a lot the Minister of Health that our advocacy was accepted and the tool was implemented at national level. From the NAP we are having and from the operational plan of antimicrobial resistance surveillance, the historical data or retrospective data was collected using the tool from our hospital. We are delighted that we've managed to have that. So apart from this combat network and e-health tool, the collaboration also continue. I don't know if you are hearing this video. The collaboration continue with the University of Berlin through implementation of the implementation or interventions relative to IMS. Once maybe this video is going to have sound, you shall hear this expert. We have Dr. Max and Dr. Miriam who work hand in hand with our services to implement some intervention relative to IMS. So this is historical background with our intervention and collaboration with the University of Berlin. So this specific project, the specific project that is funding this symposium, but also other activities relative to it as I am going to present them, was through a response to a call published by Pfizer. So we received a call, and in collaboration with lecturer in university, I and Adeboyega, you can see, I and Adeboyega, we sat together and say maybe we can make a concept note and respond to this call. Maybe by chance we can get accepted. And fortunately, we were accepted and we were granted to implement what we proposed as solution. We are happy that we are managing it well, and we are organizing such activity as you are here. In fact, being here, you and whoever who attended is contributed to it. We are delighted for this. Yes, because the university teaching hospital is implementation institution, we are being coordinated by the head of clinical education and research, because this is in the category of research, but working hand in hand with implementing department and services. The objective of the project itself are two. It is just to implement a robust antimicrobial stewardship program in our hospital, but also to have our antimicrobial susceptibility testing for diagnostic and for surveillance with very ensured good data quality. In fact, to comply with data quality required for not only surveillance, but also for diagnostic, because we start by diagnostic and then surveillance. To arrive or to implement our activity to these objectives, so we started by selecting team that is going to be acting and implementing activity. So we formed, or we organized 4 teams, namely the team or team working group that was to ensure antimicrobial susceptibility testing, AST, surveillance and diagnostic, and the team that was for clinical and stewardship, and the team that for research and education, and then the team for administration and logistics relative to this project. So the team were multidisciplinary, and they are coming from university teaching hospital, our hospital, but also a lecturer from university, specifically the College of Medicine and Health Sciences. So this is the team. This is the team of, I think you are seeing the team. So this is the team from the Chub. So it includes physician, include pharmacist, and it includes doctors from various specialty like ophthalmology, ENT. It includes lab scientists. It includes research specialists. But as I told you, everything is being implemented under the umbrella of the clinical service division, and the clinical service division is the one that is coordinating everything in clinic and everything in diagnostic, that is laboratory and whatever modality of diagnostic. So for academic, we have microbiologists that are coming from CMHS, pharmacologists and biochemistry, and these are them. We have pharmacology, microbiologists, biochemists that are working hand in hand to form a multidisciplinary team that are expert for teaching, but also expert in implementing the activity. So the second was to define roles and responsibility for this team to do intervention relative to the project. First, it was to understand the antimicrobial stewardship toolkit, that is to be as robust as it is designed in guideline, OMS or other international guideline. The second was to understand the laboratory assessment for antimicrobial resistance capacity. There is a tool that was developed by CDC to assess whether the laboratory is doing testing, but also is doing record for the data quality. So we need to understand these two tools to have a very adequate assessment and to know where we are and where we need to go. So from there, we stated project activities, but also understand that the activity are going to lead us in the objective. So each team has roles and responsibility, and we are working hand in hand to comply with whatever we targeted and the purpose. So the second intervention is that we used the LARC tool, but also the IMS-WHO tool to assess the laboratory capacity and to assess the antimicrobial stewardship status in our hospital. We tried to be as open-minded as we can without being biased that we are evaluating ourselves, but also it was good that working hand in hand with the lecturer in the university, it wasn't easy to be biased on our side. You know, those people who are lecturer and teachers, they don't like to be biased. You try to be biased and they give you 0. So then from the result of the tool, we sat down again and see the tool mainly they give result in terms of percentages, but we need to translate these percentages, but also statement of variables in actionable action point that will lead us to implement and to be as successful as we can, just to have a maintained IMS and antimicrobial resistance surveillance program. So these actionable action points were in relative to funding scope, because the funder said you can just use this money for this scope but not this. So we went in that scope, but also the scope that is dictated by the action plan of the hospital. Then we opted for these 3 main priorities: the IMS governance and leadership, and then standardized antimicrobial use, and then standardized AST data. So these are the steps. Then we started an execution of these actionable action points. So by developing document for governance of our IMS committees, policies and procedure for rational use of antimicrobials, and forms and format of AST data, but also thinking on awareness and trainings, and among other activity for awareness and training. These activities, the major one. Please, you have your notebook. As far as they are not full, please keep them, because wherever you are using it, you are helping us to make people that they know IMR exists, and people are providing money to just get this problem known by everyone. You have your notebooks, but also you have your bags. Keep your computer there and take them as this inscription are seen by everyone. Whoever even is not understanding it will ask you about it. You never know, you can just tell him one word and it's going to be contributing to the reduction. So the baseline result on what we did on IMS, you can see we scored 75%. This was the baseline, and you see that the functionality of DTC was the lowest, but if you see on IMS actions, from IMS action to the reporting, we are under 80. So from this number, we said we need on DTC, IPC, and IMS to do actionable point. That is, we say we need to have IMS team. We need to develop term of reference, develop role and responsibility of IMS, but also have a letters written and appoint the member of IPC, IMS, and DTC team. Then for IMS functionality, we needed to develop working procedure, not just intervene or do anything opportunistically, but in a way that is written. Develop annual costed action plan, classify antibiotic by aware classification, but also work in compliance and monitor whether we are implementing the working procedure adequately. So on actions, we said we need to revise our antibiotic treatment guideline. We have it, but it was expired, so it was to revise it and put in the data that we are having, but also the updated data published. To develop policy and feedback from IMS team, how we can use this feedback, and also develop policy on antimicrobial prescription and delivery. In fact, this maybe is going to be discussed in the following panel. This about IMS and about capacity on antimicrobial susceptibility testing. It was very low, 55%, but as you can see, the first driver of this low mark is about quality control. The quality control is in hand with procurement, because people need to have the ATCC to have quality control done, and these are not always available. And the second was to have identification method and SOP developed just to implement the standards of testing and recording. And the third one is to be as consistent as for panels, policy, and analysis of the record. So as intervention here, we said that because the driver relative to having supply is going to be as an advocate, but intervention that is in our hand was to standardize compliance with IST. And then we say we need to include in our reporting, but also record these 6 elements, this breakpoint from the standards, record method of testing, panel that are consistent, cascading. Cascading is selecting reporting to minimize that the clinician or prescriber can prescribe irrespective whether it's having a low level or antibiotic, then including expert rule, but also recording quality control result, but also integrating the requirement for global antimicrobial resistance reporting to have our data reported without any idenge, then interoperate with DHIS2 at the national level. That is, we went from the form you can see at the left of this PowerPoint, and we had this form, and the form was as consistent as to record the method, to record the breakpoint, to just notify the intrinsic resistance, but also expected phenotype in terms of susceptibility, but also variability of expression in terms of susceptibility, and variability or what we call inference. One antibiotic can be representing others instead of testing all, but also testing one where you are having report of them or them all, and also selective reporting, which is just to report to the clinician an antibiotic that is at the lower level, even though the higher level antibiotic is also susceptible. But also, as I said, complying with the WHONET variable that can be exported and analyzed for comparative analysis. So as a conclusion, we say that we were also going hand in hand with the theme of the day to advocate. We are also advocating to maybe scale up or generalize standard antimicrobial resistance data while automating IMS decision support for clinician, but also for those who are supplying and delivering material for testing and treatment. So educate, we need to implement a data-driven education on IMR, educate having the picture in our settings, but not only what we are reading in the book, and act now implement comprehensive antimicrobial resistance surveillance and AMS program, not in only this tertiary hospital, but at any level where antibiotic can be provided. So this is a paragraph of acknowledgement on our side. We say no effort is too small, no contribution goes unnoticed, whether by intent or by duty. Every action, every decision and every shared vision has brought us here. To all who have shaped this journey, leaders, colleagues, supporters, we extend our deepest gratitude. This symposium, like the work it represents, is a testament to power of collective effort and safeguarding health for all. Thank you very much.
Thank you for the leadership, thank you for the commitment, and thank you for the dedication. Now it's time for lunch. So we have an hour from now till 3 p.m. Once the lunch is over, then we are expected back into the auditorium. Lunch will be served at Koika. The protocol will guide us to the venue. On behalf of the DG and our invited guests, we are thankful to you for the time taken for you to participate from since the morning that we have started up till now. We wish you very bon appetit, bon appetit, bon appetit. Thank you very much. So this session is closed till 3 p.m. Thank you very much. So please, we need to tidy up. We have 2 other panel discussion after lunch, as well as 4 oral presentations. Then later in the evening, we have the cocktail. So please, take your lunch as quickly as possible, and then you return to the auditorium. Yes, in addition is that the all is safe. Whatever you have to keep, kindly do so. We have men from the logistics committee that are also going to be here till the end of the lunch session. So whatever you have, you can keep it where it is, go for lunch, and then you'll be back. Thank you. Protocol, please, let's be fast. 1 hour or less, we want us to be back by 3 p.m. Thank you. Oral presenters that are here to send their PPT should please do so via the symposium email. Thank you. very wonderful lunch. I want to request all oral presenters should please take their seat in the front row here. All oral presenters. We want to ascertain the number of those that are here. We'll be having 8 oral presenters. Please kindly move to the front seat here. Dr. Charles Winda, please let's move here. Then if you are here to send your presentation to the email, kindly do so now. Thank you. Thank you very much. I have the honor and privilege on behalf of the DG to invite Professor Dios Bazira. He's the Director for Global Health Practice and Impacts. He's also an Associate Professor of Medicine at Georgetown University Medical Center, the United States of America. And also, he doubles as the primary investigator of the Fleming Fund for Rwanda. Please, can you please give him a round of applause? So Prof will give us his goodwill message. We can all recall when Dr. Gashegu was giving his presentation, he mentioned a number of current initiatives that have been deployed, and the Fleming Fund is one of the critical interventions that is assisting in scaling up interventions across major healthcare facilities in the country. So Prof, we are delighted to have you for your goodwill message. Thank you, sir.
Good afternoon, everyone. It's a privilege and a pleasure to be here with you. This is my country. You know, he focused so much on where I work, but he didn't really talk about where I'm from. And so this is the land of my ancestors. Lots of relatives, I'm sure, somewhere in the audience that I don't even know about. Otherwise, I'm one of you. Just happen to be your ambassador somewhere else. So you will forgive me, and I'm not trying to put your organizer on the spot. I got to know about this conference or this symposium as I was jumping on a plane to come here for something totally different. And I saw the invitation. I saw my name somewhere. I ignored it because I didn't want to know what it was about. And I got here last night, and Cyprian, who has worked with me for the last almost 20 years, ambushed me this morning. And he says, I have a car ready to take you to Butare. Then after lunch, I'm seated over there, waiting to listen to the 8 presenters. And I get told that I have to come and give a word of goodwill. I don't even know what goodwill actually means. All I can say is this, that the field of antimicrobial resistance is something that I hold dear to my heart. It's one of the first things I got in as a professional long before most of you were born. I think the people in the audience. It is true, I look around, the average age is probably 20, and I've been around for more than 20 years. And so I can confidently say without fear of contradiction that I've had an interest and involvement in this field for most of my professional career. Started off mostly focusing on antimicrobial stewardship issues, working with doctors and pharmacists to ensure rational prescribing and rational drug use. But I think we lost that battle because since then, some of the antibiotics that we held dear to our hearts that really work to solve a lot of the problems we faced are no longer useful. They're no longer efficacious. Now we are going on more and more into new generation of antibiotics, and hopefully we can protect those. Because when you look at the research and development pipeline, there isn't a lot of research going on coming up with new antimicrobial agents. It's more to do with cancer, diabetes, and you know it, all these lifestyle diseases, because that's where the money is. In places like the US, there is more competition to get into a fellowship on cardiology, on orthopedic surgery, obstetrics and gynecology, than you see people wanting to get into infectious diseases, because that's no longer a priority for some of the more developed countries. Unfortunately for us, it's a twin burden. We still have to deal with infectious diseases, even as we tackle the rising burden around lifestyle conditions. So for me, this area of AMR is important, and I'll end by saying I'm supposed to be, I'm told, at a panel, so I will tell a a longer story when the time comes. But just wanted to say one thing, and Cyprian is my witness. So since this is a word of goodwill, I might as well say it. 6 years ago, I happened to be here doing something totally unrelated to AMR. It was something to do with health financing with your president, who is the champion for Africa Union domestic health financing issues. I'm sure you're aware about that. And then I was also writing a grant on AMR for Malawi at the same time. So Cyprian used to work with me at the University of Maryland, had just moved over to Georgetown, and he came to see me. So I told him what I was doing, and then before I knew it, your Minister of Health then, Dr. Diana, what is the other name? Gashumbayas, showed up also. And she said, I hear you're writing a grant for Malawi. When are you going to write one for Rwanda? I told her that I will try, but I see personally, and there are so many others who I think in this audience who believe so, I think the AMR burden is probably the most tragic silent killer that we never talk about because it's mostly not visible. I have worked in HIV for a long time, and TB and other things. Those ones are very visible. You know, when HIV was killing a lot of people, you could go into hospitals and you saw the evidence. It stared you back in the eye, but AMR does not. It kills silently. However, now that we talk about building a resilient health system, if we could figure out how to respond effectively to AMR, detect, prevent, and respond, and then build systems and infrastructure to deal with that, then would have developed a system that can deal with any other health threat. Because then we have the early warning system in place. So we've been making an argument that we need to invest more into AMR work. Unfortunately, the world and governments have not seen that as a priority. So I'm hoping that collectively we can stay and keep at it, not give up. So I never gave up. I spent the last 5 years lobbying to try and get some AMR funding into Rwanda. So that's how I ended up at the Fleming Fund. And I made a case for 5 years, then had to go through the process. And I told them, look, what I'm interested in is get Rwanda included in your investment strategy. You don't even have to fund me or fund my institution. I made a promise I would like to see it come to fruition. So it took 3 years. Eventually they included Rwanda in their list of countries they could invest in. And then last year they decided, okay, now they came and met the government. The government assured them that they were committed to responding to AMR burden. They released funding opportunity, and we teamed up with RBC as a partnership to do this. And my conversation with Professor Claude Muvunyi was, we're not going to do this as Georgetown because we don't own anything in Rwanda. We don't own any infrastructure. We don't own any lab. And therefore, we can't do this unless you're willing and ready to do it and lead. We will follow. We can bring some expertise, but it's your work. You have to lead it. You have to lead the implementation, and you've got to sustain it right from the beginning. And they said, that's the right approach. You're welcome. We did it. The rest is history. Thank you so much for the opportunity, and I wish you a successful symposium.
Thank you very much, sir. We can still do more. We can still do more. You have seen another example that money does not talk too much. Is that not so? So while we welcome the oral presenters, I would like to announce that all poster presenters should please drop their copies at the reception. Oral poster presenters, kindly drop a copy of your hard copy poster at the reception. Mr. Felix will facilitate other details about them.
In addition is to request, for this session we'll have 4 oral presentations, and they are here seated, ready to deliver and pass across very vital scientific information. The secondly, once we conclude that session, we'll be merging the 2 panels discussion, 2 and 3, in order to be able to accommodate the time that we have. So once we conclude the panel sessions, the panel session now would have the concluding part of the oral presentations. Thereafter, we'll have our cocktail. Then that ends the 1 activities. Thank you very much. So it's my honor to invite Dr. Noel Gamai for his presentation. Thank you. Please let's welcome him with a round of applause. Please, can you confirm the projection? Excellent. Each presenter has 10 minutes or less. Then we have our assessors in the room that will facilitate the results at the end of our session tomorrow. So please let's ensure that we keep to time. We appreciate if we can spend less of the allotted time. Thank you.
Yeah, good afternoon, everyone. Yeah, I'm Noel Gamai, as they mentioned, and I'm going to present the work that we did and was recently published. It was published recently in January. So we worked on prevalence of Campylobacter and its antimicrobial resistance profiles in Kigali city at 4 health facilities. This is the content. Actually, Campylobacter is one of the gram-negative bacteria, and it is among the major causes of human gastroenteritis. Every year, around 96 million cases are associated with Campylobacter. And the major species are Campylobacter jejuni and Campylobacter coli. So it's microaerophilic, which requires the addition of some of the supplements. Maybe the reason why it's not really studied a lot, mainly in our countries. Erythromycin and ciprofloxacin have been the drugs of choice, but due to increasing resistance to ciprofloxacin, now erythromycin remains the drug of choice. So the WHO has classified fluoroquinolone-resistant Campylobacter as requiring new drugs. Actually, Campylobacter is associated with food mainly. Poultry there are many reservoirs, but poultry is number 1, and it can also be transmitted through meat or even milk, and also contact eating vegetables that are contaminated with feces, mainly fecal or root. The issue is that in Rwanda there is only one study that worked on Campylobacter in humans, and that study it didn't even use culture. They went straight to PCR. So it means that we don't have even data on antimicrobial resistance. There is an issue of limited microbiology labs, because if we cannot test, we cannot know which ones. Even the one we test, Campylobacter is put aside. In animals also, there is one study and one study on food. So in the country, there are only 3 studies on Campylobacter, and it's one of the major etiologies of gastroenteritis. So this was our aim, to determine the prevalence and antimicrobial resistance of Campylobacter in Kigali. We did it at 4 health facilities, 2 hospitals, Sashika and Nyarugenge, and also Bibyogo and Muhima health centers. So it was a cross-sectional study, and we used the formula where the sample size was 385. And statistical analysis also was used during the analysis. So how we do it, how we did, we collected feces from humans, then we used what we call enrichment, using what we call Preston broth. Then from there, we subculture on a media called MCCDA. Then after 2 days, you subculture again on blood agar. Then from there, we did the PCR to determine the species. From the colonies, we did DNA extraction, then PCR, then using specific primers, we determined the species and also the genus, and then we did the electrophoresis to confirm the bands of the species we were expecting. For this antibiogram, we used disc diffusion method using 6 antibiotics, ciprofloxacin and erythromycin. That I said there are drugs of choice: streptomycin, tetracycline, and gentamicin and chloramphenicol, sometimes used as alternative treatment. Then the interpretation, we used the CLSI, Clinical Laboratory Standard Institute, which is an American standards. So in the results, okay, in the samples first, many samples were obtained from Biryogo Health Center, and also majority were from females, and the age category, it was from 17 to 50. Okay, the prevalence, it was 7%, and as I said, many were from females. Okay, when we checked on the factors that could be contributing to the infection using a chi-square, we found that diarrhea and abdominal pain were the predictors of Campylobacter infection during the bivariate analysis. During the logistic regression analysis, only the diarrhea remained as significantly associated with the infection. For the antibiogram, we found that higher resistance was seen against erythromycin and also streptomycin. And as I said, erythromycin is the drug of choice for treating Campylobacter. Due to increasing resistance to ciprofloxacin resistance, erythromycin is currently seen as the drug of choice. But we found that there is also increased resistance 66.7%. Also, we found that majority of the isolates, 25 out of 27, were Campylobacter jejuni, while 2 were Campylobacter coli. The MDR rate was also 66.7%. And we found different levels, like one isolate which was even resistant to all the 6 antibiotics we tested. So our prevalence is lower than the only study that I mentioned that was conducted in Rwanda by Dr. Kabaiza. He reported 15.5%, but for him he used PCR. It means that PCR is more sensitive than culture. So it could be understandable why ours was lower, because when you start by culture, sometimes some might be inhibited and they cannot grow. And from the isolates, we found that 25 versus 2 were jejuni and coli, which also matches with the literature that jejuni is more prevalent, mainly in chicken. C. coli is more prevalent in pigs, and in Rwanda, although we eat butter, we suspect that maybe the major reservoir it could be poultry or other sources. Increased resistance to erythromycin, which is challenging, as I mentioned, is a drug of choice. So we should be doing more research to add different hospitals to find the level of resistance to this Campylobacter, which is, I may call it, less known or less studied in Rwanda. Resistance, surprisingly, resistance to ciprofloxacin was low, 37%, which is somehow contrary to what is found in the literature, as WHO classified fluoroquinolone resistant, including ciprofloxacin, resistance among the priority pathogens for new drug discovery. So in Rwanda, was low. We also published sometimes back a literature review on Campylobacter in sub-Saharan Africa. We found that in Africa, the resistance to ciprofloxacin is not really high in Campylobacter compared to other continents. Campylobacter also infection was associated, highly associated, significantly associated with diarrhea. I cannot conclude without thanking PASET. Actually, this is one of the funders in sub-Saharan Africa, which funds some PhD program. They funded my PhD, and when I came back, they also gave some grants, like a JIRA, Junior Investigator Research Award, to continue what we did during our PhD, and because also Campylobacter was not even studied in our country. I also thank UR CST and UR CMHS, but the biology department, that helped to run, to make this study successful. Also, we thank the patient who accepted to participate in this study. So our paper was recently published, as I mentioned. Maybe you can Google it to find more details about it. It was published in the BMC Infectious Diseases recently in January. Thank you.
Charles Muinda for his presentation. After the fourth presentation, then we'll have all the questions taken together. So please let's note for each of the presenters. No, Thank you very much. So Dr. Noel was 8 minutes. So thank you for giving us 2 minutes. So we appreciate less 10 minutes.
Good afternoon. My name is Charles Muhinda. I'm so happy and honored to get this opportunity to present the findings of my research. It's about evaluation of AMR patterns in escape pathogens isolated in clinical samples at Rwanda Military Referral and Teaching Hospital. So I go through the background, research objectives, methods, and then the results of the study. So I like to begin with why AMR. So we talk about AMR because there is antibiotics. So I go back to Sir Alexander Fleming. So when he was in microbial lab dealing with Staphylococcus aureus, and they left the place on the bench and went for vacation. So when he came back and found the colonies were contaminated by the molds, and then when he observed very well, he noticed that where the substance is contaminated, the colonies were kind of being observed by the molds. So he said that perhaps this substance is actually the one killing the colonies of Staphylococcus. So he went on and purified the molds and later got penicillin, and it was used to treat many people about Staphylococcus infection. So he said that sometimes when what you are looking for is not what you get, and that's how the discovery of antibiotics is really obtained. So this is really how the antibiotic resistance is happening. So when you have a group of pathogens, one is normal flora, another one is pathogenic, one harboring the genes of resistance, innate resistance, and sharing it to the pathogenic bacteria, and end up resisting to the antibiotics. So this AMR is causing global health burden, whereby 700,000 deaths are attributed to AMR, and also they are predicting that in 2030, the deaths attributed to AMR will be 67%. And in 2050, they predict that 10 million people, 10 million deaths will be attributed to AMR. So these are the key drivers of antimicrobial resistance. I think most of the presenters talked about the overuse of antibiotics, the patient not finishing their doses, and then misuse of antibiotics in the live animal health sector, poor infection prevention and control, lack of hygiene and sanitation, and lack of antibiotics being developed. So what is the escape pathogens? So this group of pathogens were initially grouped by infectious disease, Infectious Society of America, as a hospital-acquired infection, and there are 6 of them, including Enterococcus, Staph aureus, Kleb pneumonia, Cinetobacter, Pseudomonas aeruginosa, and Enterobacter species. So they are known to be multi-drug resistant and extended drug resistant pathogens, and they highly cause hospital-acquired infections, which leads to morbidity and mortality in the hospital settings, and also increase hospital patient stay. So because of that, WHO has grouped these pathogens. They call them priority pathogens into 3 major groups. This is a critical group, high group, and medium group. So most of these escape pathogens belong to to the critical group because most of them resisted to third generation cephalosporins and also carbapenem drugs. So for all these reasons, so we decided to conduct a study because I belong to microbiology lab. I was seeing many resistant pathogens within the lab, and most of them were resistant to the AST. So we decided to conduct this study to assess the AMR patterns of escape pathogens in isolated in clinical samples that we are receiving at Rwanda Military Hospital. So the overall objective was to evaluate AMR patterns in this group of pathogens and also determine the prevalence. At least we have a baseline of what is going on in the hospital facility, and also determine the AST profile. So this was a cross-sectional study design, and it was conducted at Rwanda Military Hospital, which is a referral and teaching hospital with the laboratory that is accredited by ISO 15189. So how did we do it? So all samples that we are receiving at microbiology lab were subjected to the culture and identification. And when we identify pathogen that belongs to escape pathogens by using conventional methods, we could store them at, we use cryovials and put them in nutrient media with glycerol and put them in -80 for further identification. So I went ahead to take the isolate to King Faisal for using automated Phonex 50 for confirmation of identification and AST. So we used the Phonex 50. So overall, out of 1,940 cultures, 744 were positive, and out of these samples, 270, which is 30%, were escape pathogens. So I took these samples to confirm by King Faisal. Some of them, the ones that were able to be confirmed on Phoenix 161. So the distribution of escape pathogens, we found that Klebsiella pneumonia was the highest prevalent in the hospital facility, followed by Staph aureus, Acinetobacter, and the rest of escape pathogens. So in a clinical specimen, you can see that Acinetobacter baumannii was high in tracheoaspirate, and also Klebsiella pneumonia was high in urine samples. So when we see the escape distribution by ward, you can see that Acinetobacter baumannii is high in ICU. So you can understand how severe and problematic this is causing, because if you have multi-drug resistant pathogen in the intensive care unit, so you can imagine what will happen if there is no choice of antibiotics left to treat this pathogen. So another finding is that in a total of Klebsiella pneumonia that were isolated, 65.2% were ESBL producer. This is extended spectrum beta-lactamase producing bacteria, which are resistant to all third generation cephalosporins that were tested. We also noticed that out of 21 isolates of Acinetobacter baumannii, 84.2% were carbapenemase producing Acinetobacter baumannii. So the overall gram-negative had 10% resistant to carbapenem drugs. Yeah, so in Staphylococcus aureus, we tried to map the resistant genes, the MARCA gene that encodes resistance to MRSA, and we found that it is 4.70%, which is, 4.70%. Because not all MRSA are resistant to oxacillin, they have two different resistant mechanisms. One is beta-lactamase encoded, another one is MARCA gene related. So you can see oxacillin is 6.6, vancomycin is 4.4, and clindamycin is 6.6 as well. So this phonics has the capacity to map, to screen the resistance markers while testing. So this slide shows the map of resistance markers within the isolated pathogens. So you can see the SBR in Klebsiella is too high, which is 43 out of 66, and then Acinetobacter, and then Staph aureus. We are indicating MRSA gene in all tested Staphylococcus. So the key findings, we noticed that in escape pathogens, there is high ESBL and CARB in gram negative. And also, we are not able to, in all isolated Staphylococcus aureus, we notice the low prevalence of MRSA. When we went to confirm the Enterococcus on the phonics, we did not confirm because AP20 were telling us Enterococcus species, but we thought we are going to get Enterococcus facium, but there was no confirmation even on the phonics. So we noticed that these findings are going to strengthen the local antibiotic guidelines, improve IPC measures, and then build the capacity in AMR surveillance, and also inform AMR strategies to combat AMR. So to conclude, escape pathogens frequently recovered in hospital facilities. Most of them are SBL and CARB producing isolates and need investment because we are comparing also the AP20 and the automated systems. So also this is actually a first study on escape, so we recommend to scale up this study in a bigger hospital setting. Yeah, thank you so much. I want to acknowledge Rwanda Military Referral and Teaching Hospital for sponsoring me to conduct this study, my staff in bacteriology, and also to thank the organizers of this symposium to give us opportunity to share the findings of what is going on in our hospital facility. Thank you so much for your kind attention.
Thank you very much, sir. So now we invite Dr. Isa for his presentation.
Thank you. My name is Isa Gawanziza. You can't see the slide? I am a physician, clinician working in Jumba Level 2 Teaching Hospital. And Jumba is also one of the beneficiaries of Pfizer Fleming funds. We are now able to do microbiology tests. So we are thankful and grateful for the advocacy you did, Mr. Professor. So my presentation, I think the 10 minutes I respect it. It's a kind of retrospective study done at the Nyagatare District Hospital, 2019. I was about to look the prevalence, behavior of clinicians around patients presenting with fever. So why fever? Because for some clinicians, fever equal to antibiotics. One of my colleague, DG of Chijeme, talked about this in the morning, about the burden of antibiotic use, especially in the hospital, health center, and even in the community. So the district hospitals, most of people here presented the referral teaching hospitals which have the capacity to do microbiology with cultures. Up to now, only I think the referrals and the level 2 teaching hospitals, other district hospitals, we can't do routine microbiology tests, including culture. When only we need to do survey, we send samples to national laboratory. So the diagnosis is sometimes limited, and these contribute to abuse of antibiotics. So my study, as I said, was to see the prevalence, diagnosis, antimicrobial use, and then this was done in a district hospital. What is fever? You all know, but just for us, we said any patient having an auxiliary temperature of 37.5 and beyond was having a fever. And the temperature can vary on day by day. Some people say even over the decades, the temperature of human being has been declining. And the cause can be environmental, inflammatory. So 74% of patients admitted in hospital comes with fever. I think fever after pain is the most common symptoms at admission in district hospital. And so other causes of fever also include cancer, ischemia, drugs, that all often mislead clinicians to prescribe antibiotics without proper diagnosis. So the characterization is important for clinicians to know the source of fever. It can be either continuous, intermittent, relapsing fever. It can have associated symptoms like chills, sweat, rash, jaundice, and joint pains. All of these, we orient the clinicians if they do proper history, physical exam, and investigation to know when and where to give and what antibiotics to give into patients, especially in these settings that I'm talking about don't have the microbiology capacity to identify the germs. So Nyagatare, those who know, is in the Eastern Province, is the largest district with 2 district hospitals, a lot of health centers, a busy hospital, around 700 people in the same district. And the laboratory capacity is also unable to perform cultures. The other challenge that also is found in Nyagatare but also across other district hospitals include the auto-medication from private pharmacy, private clinics, including traditional medicines, which also can precipitate inflammation and infection and fever. So we assembled a data collection form. We gathered information from the electronic medical records that the hospital use and patients file. And so we recorded all data, demographic, symptoms, diagnosis, test, and treatment done. We included any patient admitted internal medicine. So in Rwanda, internal medicine, we admit 15 and above who has fever on admission. And so we put emphasis on antibiotic pattern. So the type, the time, the combination of antibiotic, and so on. The statistical data we used was SPSS. Of course, we have applied for the ethical consideration from the hospital, and because it was a retrospective, we did not mention the names of the patients. And the study, because it was in nature, is limited because we could not take the whole year. We just took 5 months, so we cannot characterize the fever pattern all along the year. So there could be variation across months and seasons. So the results, we have collected data from 191 cases, and most of the cases from to September, from July. We could not explain why. Female patients predominate, as even if you see the number of patients, female are always, or not always, but most of the district hospitals, more female patients come to hospital. Occupation, so this is the rural area, they are farmers, and most of them have acute illness 2 to 7 days, so with fever. That means people tend to present early when they have fever. The most common symptoms associated with fever was headache, abdominal pain, and diarrhea. And flow blood count was the most requested exam in 92% of cases. And I think it is similar to other district hospitals as well. Diagnosis, we considered the diagnosis at a discharge, when the patient was discharged, because you can have several differential diagnoses, but most of the cases we see sepsis, which has different understanding according to clinician, pneumonia, typhoid, which also is symptomatic diagnosis because you could not do culture, urinary tract infection, and so these are the common diagnoses put on discharge form. 82% were given antimicrobials, not only antibiotics, but among them 80% were given antibiotics within 24 hours, empirical. And this does not go with the clinical presentation of the patient. So if you have fever, you could start antibiotics, provided that even if you have stable vital signs. The most antibiotic given was cephalosporin, and remember this is the broad spectrum antibiotics we have at the district hospital. So even if you are not critically ill, they will start cephalosporin, ceftriaxone or cephaloxime in pediatric population. But for us it was adults, so it was ceftriaxone. As we did not have culture sample at the district, we could not determine the sensitivity and resistance pattern. So this basically was the study we did. It was to characterize the fever, behavior, how frequent it is, how clinicians behave towards it, and if you compare with the other settings where they have microbiology, we see that we have gaps from the physical examination, history taking, to the investigation correlation with the clinical symptoms, and to the empirical treatment. Because if you see, we have seen that every patient, 80% would be put on antibiotics. But if you see in the developed settings, less than 50% are put on antibiotics, and after a thorough physical and laboratory investigation. So we recommend that clinician, the district hospital health center, do a continuous professional development on AMR and AMS, establish AMS in each district hospital, do thorough physical clinical examination, and only prescribe broad spectrum antibiotics if it's really worth it. For the policymakers, that study was done in 2019. Already some measures are being taken to increase the capacity of diagnosis in district hospitals. We are now at level 2 teaching hospitals, with some few district hospitals where they have partners other than the government. And then to put regulations on antibiotics using the AWARE classification. Some people in the morning talked about this. So we should have the available watch and reserve antibiotics, even on the national or even each hospital. And I thank you for your kind attention.
Thank you very much, sir. Now, as part of our mentorship program, is to have one of our students in training to be part of this presentation. So I have the honor to invite my brother, Pacific, for his presentation. He's a level 2 pharmacy student. Please, can you please motivate him more? I remember I was taking their class, microbiology 2, and I informed them about this symposium, and out of about a number of them that are seated here, is one of those whose abstract was accepted for presentation. So we are delighted we are here. Please go ahead.
Thank you very much. I'm honored to stand here in front of these great people I wish to become in future by Almighty, God blessing. So far, let me start. As I'm a student, I didn't go far into deep research, but I tried and I get an opportunity to have the experts like our lecturers. They try to guide us in the way to overcome or to analyze different challenges. So we are talking about MRI as it's becoming threat in this generation. Normally, according to my research, I have seen that annually it almost took 1.27 million annually due to these threats of MRI. So let me dive in, but I'm not going to talk about much because all my researches were from the internet. First of all, they have defined the term MRI. I hope everyone in this room, you know the definition of MRI. And you can even explain that to even someone who does not have that skills. You have that potential to explain that to even someone who is illiterate. And that's what this symposium is about, is to educate, advocate, and act now. So I hope you're going home with something, with some knowledge to help in the society, to advocate, to educate our fellows at home. So I find 3 key points I'm going to talk about. First of all, we have the problem of data-driven approach in MRI surveillance. And due to that problem, as a student, I try to see how I can dive in that problem. We are in the world of technology. I would recommend provision of AI because it has the ability to analyze a vast range of data and give us the accurate and speedy information about the data. So that's why I tried to bring this to the table about the AI. Not only that, I also tried genomic sequence. When I say genomic sequence, as a scientist, we analyze or we decode the DNA of a bacteria or a virus so that we be able to analyze or to detect where that resistance will come from. So as a student, we are trying to, as we have the opportunity, we have some labs here, we have the ability to attend those labs. We have the ability to analyze their DNA. If you, for example, if you know someone that he's the best at, let's take an example, he's the best at scoring goals from the corner, you'll be able to emphasize the power to that corner so that he cannot win you any given goal. So that's why we are trying, in case of stacking to the MRI, analyzing those antimicrobial resistance, where it comes from, we just tackle to the DNA of any microbes we are dealing with. For example, we have the example like gonorrhea. In the past, we used to use antibiotic of penicillin was easy to treat gonorrhea, but now due to its resistance developing, it's almost antibiotics are not working on gonorrhea virus. That's why when you are going to deal with that kind of gonorrhea, we're going to tackle on its DNA so that we can be able to analyze or to detect it before it even kills us. Furthermore, I tried, as you have seen here on my slides, I'm dealing with stewardship. Stewardship, as we understand antimicrobial stewardship, it helps us to be able to give what is needed to the kind of the disease we are dealing with. Okay, in the past, our parents used to give us some drugs and if you are feeling headache, it will just give you paracetamol without even diagnosis of that. You just feel that if you are feeling a headache, you have that kind of, you can take paracetamol and it goes away. But currently, we are able to have such education, not just to take any kind of medication because we are feeling the same signs as my colleague is feeling. That's why stewardship is very important. Every kind of medication, as our lecturer said, Ezra, we have to have policy makers would emphasize on prescription. Not just as I'm a pharma student, I'm going to be dispensing or trying the different researches. We are not allowed just to dispense because according to the science we have been told, we have to diagnose just to prevent misuse of antibiotics. And you know that when we misuse those kind of antibiotics, we are just developing resistance to different areas. So we have to be able and sure that the antibiotic being given to kind of patient is really according to that kind of disease he has or she has. So not just taking too much of your time. I think as a student we have like a request to our RBC. It's an honor just to have this kind of institution in our house here in the auditorium. As a student, we just for the first and all, we are thanking you for this opportunity you're giving us to be able to present what our ideas. I might be having small knowledge about this, but furthermore, I'm looking forward to fight with you to step ahead to what you have already built, to make a strong resistance about this MRI. So thank you for your kind attention.
Can we still do more? We can do better. I remember my first level presentation was when I was in year 3. One of my lecturer requested that I need to present at an international conference, and that was how I started. So we have also started. Never mind, you have done the best you can, and we hope that further effort will be better than what has just been concluded. So I have the honor now to hand over to Dr. Rashid Adeyemo of the Department of Microbiology to moderate the session on the question and answer. I will plead that we make it as brief as possible. Okay. So we're glad to round off in about 20 minutes to enable us proceed into the next session. Thank you.
Thank you very much, ladies and gentlemen. This is the question and answer session for the just concluded presentations. We have listened to the gospel according to the words of Dr. Noel, Charles, Pacific, and Dr. Isa. So the floor is open now for questions. So please, if you have questions, just raise up your hand, and the microphone will be circulated around to take your questions. Thank you very much. So please raise up your hand so that we can take counts.
so much. My name is Blaise Pascal Ishimwe. I'm working with Pfizer. My question goes to the gentleman from Rwanda Military Hospital. A nice research and data. I would like to know how are they managing the patient or the pathogen that are resistant to carbapenem, MAS. So what are you doing? Because the statistics you showed us, they are very high. Acetylcholine is one of the pathogens that are highly killing people. How do you manage it? Furthermore, studied the attribution to the death or associated with in your research. Do you have some data on that? Thank you so much.
Yes, any other question?
Thank you so much. Mine goes to my colleague from Byumba Hospital. We have seen that many patients with fever, around 85% were treated with antibiotics. I don't know, they did manage to see whether the antibiotics were really needed or if there is some part of viral infections, even though maybe they don't have data. But what we can learn from it is that we are probably over-prescribing antibiotics.
Thank you very much. I'm Jules Ndoli. I would like to know from Nyagatare Hospital, with the challenges that the DG mentioned, how far the Fleming project will address some of them.
Any other question, please, before the commencement of answers to the questions? If there is none, please, Dr. Charles, Charles, yes, kindly answer your question.
Yes, thank you so much, Dr. Pasco, for a nice question. Yeah, as we know, the first step to address the problem of AMR is to know if it is there or not. So this was like a baseline survey to assess the presence of this escape pathogen in the hospital facility. So number two, the second intervention is to make sure the hospital establish the AMS program within the facility, which includes the IPC committees, AMS committees, and then they make sure they meet regularly to address, and then they put in place the collaboration between microbiology lab and then the clinician interface, and then they have data from the lab. Most of the challenge is having no microbiology investigation in place, because we do not know what is going on. We will be prescribing, and no response to from the patient. But if the data is telling you what is happening, then you know which intervention you are going to put in place. So far, RMH has established the AMS committee. IPC committee are now working. And then laboratory now is also working. So they are having data to discuss about how to mitigate the AMR transmission within the facility. Thank you so much.
Thank you very much. Dr. Issa, the floor is yours.
Thank you, Prof. Theo. I think the first question was, could there be other causes of fever in Nyagatare, and if you could have identified the other causes. So what we did was basically going back to the clinical work. So the physical exam, the history taking, the recording of what have been identified. So what we saw, there is one sentence that I put in my presentation. 90% of all patients who were admitted were discharged stable. So that means some people, only 10%, some of them have been referred to tertiary hospital and others died. We don't know the cause. But obviously there is other causes of fever other than bacteria because 90% success rate would be not appropriate in district hospital. Unfortunately, as we could not do culture or viral testing, we could not identify which is causing fever in those particular patients. For the second question, the benefits of Fleming funds to Nyagatare, I think the whole country is benefiting because now if we can have more than 10 or 12 sites where they can do cultures. Now I am in Byumba. From Byumba to Nyagatare is 1 hour and a half drive. So it's easier to send sample to Byumba than to send sample to Kigali for microbiology. And the response should be quicker than the national laboratory. So they are benefiting. Of course, some of the patients, they can also come to Byumba. Now we are teaching hospital, we are developing ourselves to have. But I hope that also Nyagatare will benefit itself to be enrolled maybe in the next sessions to be able to do microbiology. Thank you.
Thank you very much. Do you have a question? Okay.
Thank you very much. My name is Jibril Barushman. I have 2 questions to Dr. Gahmanyi. The first question is about the 27 isolate. I saw that it was isolated on many samples. And the question is how the association of that isolate was linked to diarrhea, yet you had a lot of samples. So this association I didn't understand. The second question is about the 27 isolate relative to the calculation of resistance or susceptibility rate. Though it is good to hear that it is very low number, but I don't know how you take this rate as significant, yet we have this low number of cases to do AST rate. Thank you.
Dr. Noel, you may kindly respond.
Okay, yeah, thank you. The correlation between diarrhea and the infection, okay, it's because we were checking how many among the positives had diarrhea. So there was a positive correlation between diarrhea and the Campylobacter infections. For the susceptibility, although it was, we had a few sample or few isolates. Okay, maybe I could add, we may interpret with caution. Yeah, that one I do agree with you, because we have less isolates. The less you get with resistance could somehow bias maybe the percentage of resistance. Maybe that's why I said, actual country, we have 2 other studies that are ongoing in Ruhengeri and also in Kigali, another hospital, to see in the other hospitals how is it. But from the preliminary findings, it is still low, because among like 185, we are seeing like 16 again. So the prevalence of Campylobacter is in general low when you pass by culture. If you pass by directly to PCR, you may get more, but by culture it is less. But even if it is less, it is an issue because the treatment of diarrhea is done empirically without knowing the cause. So like ciprofloxacin could be used and it could lead to fuel the issue of resistance.
With this negative culture on Campylobacter, yet they have diarrhea. So I don't understand this association, yet this negativity also can occur.
Okay, maybe we can discuss more on this association, but that is how it was calculated.
Thank you very much. In the absence of any other question, we can move to the next item on the agenda, which is a panel discussion on Antimicrobial Stewardship Program, implementation and challenges.
So to moderate this session is our sister, Dr. Felicite Kamana. But before then, I want all the oral presenters to please stand up for photograph, please. Please, can you give them a round of applause? They have done very well, and part of what is also expected is the art of communication. Whatever a scientist might have done in the lab or wherever he or she might have experimented. No, you cannot go. Come back here. No, photo. Dr. Noel, please, photograph is part of the documentation process that they were here. Clearance were made for every of them to participate. So please smile. The microbes are also smiling. Yes, thank you very much. We appreciate you for the interest, support, and communication as well too. Thank you. So we move to the next session. Glad that we'll be having 7-member panelists, and they will speak to the second and the third panel discussion as communicated by Dr. Rashid. So I hand over to Dr. Felicite. Thank you.
Good afternoon, everybody. So we are now going to proceed with the second session of our panel discussion, and we have 7 panelists. In the same occasion, I would like to call upon Professor Deus Bazila goes to Dr. Sylvain Habarurema. He's also a physician, and he's an experienced medical doctor in internal medicine. My question is about the key component of a successful antimicrobial stewardship program. What do you think about it? How can we go? What are the key components to succeed in our antimicrobial stewardship program?
Thank you for the question. For a successful antimicrobial stewardship program implementation, the key component includes, first of all, the leadership commitment. This is a very crucial key component, as without commitment from the leadership in any given institution, the IMS program can't be implemented easily. Second, the accountability from the multidisciplinary team is very important. Also, another key component in running the antimicrobial stewardship program is to have the antimicrobial use monitoring system in place. Also, for a successful antimicrobial stewardship program, in any institution, we need to have a continuous education and training. Of course, we need also to have a feedback mechanism. As Prof. Theogene mentioned it before, you can't have an antimicrobial stewardship program running in an institution without having a collaboration from the infection prevention control team. Those components are very crucial to run an antimicrobial stewardship program in a given institution. Thank you.
Thank you very much, Dr. Sylvain. One of the main key components talked about the commitment of the leadership. Yeah, that is very important. But as we are in low-income countries, we may also face some challenges while implementing our antimicrobial stewardship programs. Can you tell us about those challenges that can be faced vis-a-vis our settings? Thank you.
Thank you. In low resource settings, we face many challenges to implement this antimicrobial stewardship program. One of the prevalent or the common challenge we face is the low testing capacity for our laboratory settings. Another one is that we face sometimes insufficient number of trained people. For example, infectious disease specialists, and also we don't have enough number of microbiologists in our country. And also another challenge is there is a low capacity to access some antimicrobials. Sometimes physicians are obliged to prescribe what are available on the market. This is also a challenge we face, like in a low resource setting.
Thank you. Before you handle the microphone, I have one more question for you. Do you think patient-related challenges exist too in our settings? I mean patient-related challenges.
Yeah, thank you. There are many challenges related to patients, especially the health literacy of our patient is limited. So to have this AMS program running smoothly, we need to educate them. We have to educate them about the benefit of complying to the prescribed treatment. We have to educate them about getting medication prescribed by physician or by doctors without buying medication over counter. By educating them, we will be promoting the rational use of the antimicrobials, and also we will be promoting this AMS program implementation. Thank you.
Thank you very much, Dr. Sylvain. The next question goes to pharmacist Denise Newturamya, who is here as a representative of National Pharmacy Council. So Denise, my question is about the role of National Pharmacist Council in ensuring proper implementation of antimicrobial stewardship program, and what strategies are in place to promote responsible prescription and dispensing of antimicrobial in Rwanda.
Thanks a lot for the question. As you have said, my name is Denise. I'm the operations manager at the National Pharmacy Council, and I have been working in this area of antimicrobial resistance since so many years, since I started working with the council. So I'm part of the team who has been implementing the NAP1 and also developing and implementing the NAP2. I think from there I become a familiar face to many. I remember recently I was attending a symposium with the team from Seashika, and one of the senior told me that when he thinks of IMS, the first face that comes to his mind is my own face, even though he couldn't remember my name. So that's the first role of the National Pharmacy Council. We are actively involved in implementing the National Action Plan on antimicrobial resistance because we are so much concerned with the antimicrobial use. Actually, the mission of the National Pharmacy Council is public health protection through regulation of the pharmacy profession. That means by ensuring that all registered pharmacy profession comply with the rules and regulation that govern pharmacy practice. So our role in IMS involves ensuring that even pharmacists don't dispense antimicrobials without medical prescription, as one of the colleagues was asking in the public. You can remember that Dr. Noel highlighted my name because he knew that recently we were discussing the same problem in the audience where we have been, and we took some step to enroll the pharmacy, private pharmacy, in the antimicrobial stewardship program. Actually, when we were developing antimicrobial stewardship program for healthcare setting, we ensured that community pharmacies, private pharmacies, are highlighted in the stewardship guideline and the necessary step to ensure that they comply with the responsible dispensing of antimicrobials. So that we are looking forward to implement in the coming days. Don't be tired of us. And that we cannot accomplish it as the National Pharmacy Council. We work in collaboration with the One Health unit at RBC, but also we work in collaboration with Rwanda FDA. So what have we achieved so far as the National Pharmacy Council in line with the antimicrobial stewardship program? Apart from the general implementation of NAP1, we actively participated in the implementation of NAP2 and ensure that all necessary steps and intervention that are there to optimize the use of antimicrobials are very well highlighted. When the NAP2 is published, you will see that in strategic objective 4 is very comprehensive. From the hospitals to the community level, all the necessary intervention were highlighted. And also, as the National Pharmacy Council also, we took the next step. We collaborated with the RBC in hosting the first international conference on antimicrobial resistance, where the National Action Plan on Antimicrobial Resistance was launched in November. I think some of you might have attended the conference, but mainly in that conference, 500 pharmacists attended it in person. So the number of pharmacists who were in the conference was overtaking anyone else, because we are so much concerned with the antimicrobial resistance, but also other pharmacists who couldn't attend in person attended online. So that's not only. We have been incorporating the IMR in our CPD program, because I think council are known for the continuing professional education. So we highlight that in our CPD activities, and so far we have seen that many pharmacists are interested in undertaking the CPD activity in terms of IMR. So in general, we are involved in all programs that are related to IMS program in the country, and about the strategies in the country relating to responsible dispensing and antimicrobial use. They are general, as other panelists have highlighted before. We have so many ongoing. Even this symposium itself is about highlighting the need of the best use of antimicrobials and responsible use of antimicrobials, and so many interventions, including the surveillance program, IMS program in the hospitals, all of them, the aware classification that other people have been highlighting, all are about the responsible dispensing and use of antimicrobials. So that's not unique for the National Pharmacy Council. I think it's all of us. We are all concerned about the antimicrobial use, and we hope that with the collaborative effort of all of us, we shall achieve the objective. Thank you.
Thank you very much for your contribution in antimicrobial stewardship program. As we have clinicians, we have pharmacists already in place and at work, but we also have students who are being trained in medicine, in pharmacy, in nursing. That's why my next question is going to pharmacist Safari, who is here as a lecturer at College of Medicine and Health Sciences. So, Mr. Safari, given the growing threat of antimicrobial resistance, what's a strategy and what is the role of a teaching institution in strengthening antimicrobial stewardship implementation in health institutions, but specifically in the area of policy development, education, and interdisciplinary collaboration?
Thank you for the question. As the training institution in health sciences, in medical sciences, in pharmacy sciences, like you mentioned, all different health professions, the university may contribute to those last tricky points you mentioned, like in research, like in policy development, in education, as well as in collaboration, by helping the health facilities. So there is this collaboration. Let me start first. There is no medical university, health teaching university without having a health facility where you have those practicals. In the morning, like the vice dean of the School of Medicine and Pharmacy highlighted, we teach in class. And in the afternoon, there are practicals in the lab. so that you can show students what you have been telling verbally, how is it done practically in the lab, but that's not on the person, on the real person. So to have this, if I can start by the University of Rwanda where I'm based, but I can also talk about the other health teaching university in Rwanda, where I have also that experience. I know how they do train this, but similar way of doing it. Like here at the University of Rwanda, we have the first 3 years, or which may be, but first 2 years and the third year to have the student starting the clinical practice. But the first 2 years is to tell them what they should be doing, what the basic science for practice, for treating a patient, for treating people, for taking care of people. And from the year 3, they have to undergo what we call a white coat ceremony to tell them, especially the role. Why should you putting on the white coat? And what does it mean, by the way? And how will you be using it? So that they start going into those health facility, which facilitate also in teaching. In Rwanda, we have those teaching hospitals, which are well known, and we have level 2 teaching hospitals as well, which came as following the ministry strategy to increase the health workforce, 4x4 strategy. Then we had this level 2 teaching hospitals to help the training universities into this health workforce. So in policy development, mainly the university focus on research to provide evidence-based practice. And if we come to the AMR, including the antimicrobial stewardship, the university is a hub for research. If you are an academician, among your key responsibility, there is research, there is education, and the community engagement. So the main, you should be involved into those research. As faculty members, we should be investing into research to provide evidence on the MR patterns. We have some presenters who have shown us different resistance trends on different pathogens, how the antibiotics developed the certain resistance, so the university can contribute to show these MR trends. And they can also evaluate some AMS intervention. Like you can design an antimicrobial stewardship intervention you want to implement in a given facility or in a country, then you can evaluate its effectiveness to show for policy implementation, for policy formulation and the briefing. You can also help to have those guidelines which have evidence through that research that has been done. The other thing, I talked about that there is this lecture classes, lecture session, lab at the university, but there is also the link with the teaching universities, including Sashibe is a teaching hospital, which facilitate, which help in the training, the future healthcare professionals for Rwanda and for the world as well. So with this, we can work, the university work with the hospital to develop and implement some policies related if we are here in the AMS, AMR, so we can formulate together what can be done and to adhere to the local regulations and the other guiding documents. We can also facilitate the hospitals, the teaching hospitals, to adapt the local, the national guidelines, including the international one, to make them adapted into the local context so that you can use available infrastructures. We have seen like a presentation from Nyagatare. They just do empirical prescribing, no facility for the diagnosis, except just to look at the febrile state of a patient. So going to the education, I talked it for the student, but also we can have the education for the professionals. Like Denise highlighted the continuous professional development. So this is a key area to be used as a CPD so that we can engage that multidisciplinary collaboration, having everyone on a table. So at the university, looking at the curriculum, there have been incorporation of this antimicrobial resistance into the curriculum we teach, mainly in pharmacology, like when we are teaching the pharmacology of antimicrobials, and also in the infectious disease diagnosis and the treatment, as well as in the different mechanism of resistance when it comes to the microbiology practices, and also the principles of antimicrobial stewardship for health professionals looking at the collaboration. And this is taught to medical student, dental student, nursing, pharmacy student, the laboratory, this student doing the biomedical laboratory sciences. Everyone take pharmacology. Through that pharmacology module, they are taught about the antimicrobial resistance and how to help prevent this. And we can also do the other thing we call the public awareness. We have student-led organization, different health professions they have. We have the MEDSA, we have the RPSA, we have the laboratory student association. I don't remember how it is called, environmental. All those associations, we are telling them or teaching them to collaborate and work together, especially when it comes to the awareness about the antimicrobial resistance. What we hope to have soon or anytime soon is to see the health professions who can sit on the same table having same understanding with the same weight of this global threat of AMR. Like feeling that everyone is a clinician. For me, I feel sometimes offended when someone says clinicians and the pharmacist. So this means the pharmacists are not part of that, are not clinicians, while this pharmacist is part of those people. So we need to see a physician, a pharmacist, a nurse, a dental surgeon being on the same table, talking on the patient, looking how best to treat that patient. So that's what we are teaching these students, to collaborate when they are managing these patients. And the university is well engaged into this public engagement outreach campaign, and we are mentoring these students through their organization whenever any campaign is happening around. Coming to interdisciplinary collaboration, I think I tackled this when I discussed this, but also not only in teaching, in education, the university can collaborate with both teaching hospitals in research and education, but also with other research organizations and the other universities like the University of Georgetown. I can give an example, can collaborate with the University of Rwanda in a given field of research, especially to foster that spirit of working together, of that we have collective will, collective vision to have a healthier world. So in summary, that's what I can tell. Different strategy we can use, and I can end up by saying that being together can give more strength. Thank you.
Thank you very much, Pharmacist Safari. Speaking of collaboration, my question goes to Mr. Benimana, who is the Director of Nursing and Midwifery at Sashi Bay. What is the role of nursing community in antimicrobial stewardship program implementation? What is the role of nursing?
Yeah, thank you. I'm Oswald Benimana, and I'm here representing the NCNM staff who couldn't attend because this symposium coincided with the other board meeting. So the role of nurses and midwives in this AMR program, first of all, it's about the implementation of IPC measures. And from the previous presenters, we have seen that the IPC play big role in trying to cut off the chain of the infection. So by applying these IPC principles, we need to make sure that there is cleanliness of the patient surroundings. And also, we need to make sure that we use different aseptic techniques during or throughout all of the procedures. And of course, to make sure that we use a clear disinfecting technique or appropriate disinfection of the equipment we are using so that we can cut off the cross-contamination. The other role, it's about a patient and family education, mainly about the compliance or just respecting the antibiotic use and avoid the misuse. And also, we try to educate them about the risk factors for potential resistance and how do they need to behave whenever they have the features of those resistance. The other major role is about the antibiotic administration. We need to make sure that we safely give the prescribed drugs and avoiding maybe some near misses, because once the patient may go without taking the whole set of the dose prescribed, it might contribute to the development of those resistance, as we are saying. And also, we play a role in monitoring the patients for the effectiveness of the treatment that are being provided, and also to try to monitor some drug reactions and even possible side effects that might develop throughout the course of those antibiotic therapy. We play also big role in data collection and the reporting, like from our setting at Chub, from the point prevalence surveys that have been conducted to get the baseline. Above 80% of the data collectors were trained nurses and the midwives. They have been trained throughout this program, which we appreciated because it contributed to the capacity development of our personnel, but also in turn, it contributed in collecting data so that it can inform the decision makers. We do also collaborate and communicate with other healthcare professionals, especially medical doctors, during the ward rounds, where we can advocate for the patient depending on their status. And from that point, we can even suggest when it's time to do the escalation, to shift from the IV to PO and so on, depending on the status or the effectiveness of the patient, the effectiveness of the treatment that the patient is receiving. We do also emphasis on documentation, where we need to make sure that we clearly document everything regarding the antibiotic, the patient identification, any drug reactions, and also the effectiveness of the drug that the patient has received. I think that's our major roles in the implementation of this AMR program. Thank you.
Thank you very much. You really play a very big role in hospitals, health centers, and that you advocate for them. Here we have got also some partners who play a big role in our IMS, IMR program interventions. So let our next question go to Prof. Deus Bazira. And actually, I want to know how can multi-sectorial partnership, how can it enhance sustainability of antimicrobial stewardship and antimicrobial resistance interventions? Thank you.
You see technology. Thank you for that question. Antimicrobial resistance cannot be addressed through one sector approach or through one discipline or through one clinical function. The reason we advocate for a One Health approach is because this is a problem that is caused by what happens within the human health, the animal health, the environment. So all these things contribute to the problem, and therefore, if you want to solve the problem, you've got to get all these sectors involved in that. If you only focus on the human side, meanwhile you are leaving the food that we eat, you're leaving the animals that also contribute to the problem. Meanwhile, veterinarians are busy using and misusing antibiotics within the animal sector, you're still going to end up with a resistance problem. Because you've heard of this farm to table, you know, others will talk about fish to table, and now we even have climate change that is coming in. So all of these things that contribute to the problem, and therefore to solve it, you've got to have everybody around the table. So that's one thing I would say. From a partnership perspective, any country exists within a broader ecosystem. So you're in Rwanda, but Rwanda is part of East Africa, it's part of Africa, and it's part of the global community. Antimicrobial resistance does not necessarily respect borders per se, okay? Because you've got free movement of people and goods and animals across borders, so the problem also follows these movement patterns. And therefore, if you want to solve the problem, you've got to establish mechanisms for collaborating across countries. And therefore, the need for all those different stakeholders that are involved in that ecosystem, whether it's at the national level, if you're at a country, the government will always have its own partners, you have the private sector, you have the faith sector, you've got the most important of all, the people within the community, those are important folks you have to have at the table. But you also have sometimes these global institutions, like the UN agencies, you have bilateral relations with other governments that have an interest in this same area. So being able to bring everybody together towards a common cause, so that it's not only a whole of government approach, it's also a whole of society approach. And when I say society, it's the bigger society than just your borders as a country. And then of course, it's an interdisciplinary approach, because this is the one area where you put to test the concept of what interdisciplinarity means, as opposed to just only multidisciplinary approaches. So we should be having sociologists as part of this conversation. We should be having lots of economists as part of this discussion. When you look at the economic burden of AMR, billions and billions of dollars we've talked about in terms of lost productivity, but also the additional healthcare costs that are imposed on the healthcare system. The people who are going to help you understand and quantify that problem and interpret it for your policymakers, most likely they will be economists. And those are the ones that most likely the ministries of finance will listen to. Not that I have anything against the health professionals in this field, but we tend to talk to ourselves. We tend to quantify the problems based on morbidity and mortality burdens, which is not the language your ministers of finance and your bankers and the private sector CEOs will understand. For them, it's got to be, if you're talking to CEO of MTN, and you're trying to find support from them, you have to talk about it from, the lost productivity costs to MTN when the employees are out there seeking health care because they are victims of AMR. The Minister of Finance will only understand it from the additional healthcare costs plus the productivity loss that the country faces. So that's why you need to have a whole lot of different partners around the table, and of course the global community, because this is also a global burden. It's not just restricted to the country boundary. Thank you.
Thank you very much, Prof, for your contribution, and to Prof. Varivira, what the funding mechanism that can be established to ensure a long-term success of IMS, IMR interventions? Thank you.
Yes, thank you for the question. I have been working here since from 2000 to 2002, 2006. I was working in pediatrics, and with the Dr. Marie-Claude, we published one paper in 2003 because I was seeing some data about infection in newborns, and we did a study in Africa and in CHUB here, and at this time, Klebsiella were one for predominant in newborn sepsis newborn, and there was already resistance in 2003. So what I want to say is that I was really a long time ago very concerned about the outcome, the patient outcome in terms of infection in pediatric and the newborn especially. So now about the question of funding, I think I'm going to give my opinion. Prof. Bazira will complement. I think that it's a question of responsibility and accountability, and the responsibility of the responsibility of health of population in the nation. It's the responsibility come to Minister of Health, to the institution leading the health implementation in the country. So in terms of funding, I think we have been looking at two different programs developing here, maternal child health program, etc. There are a lot, at least before, now it is coming difficult to find a lot of funding. But if you do remember, there was a lot of intervention, a lot of partners bringing funding in the country, and having the funding which are not streamlined by the government, it can be a problem and it can be inefficient. So my point of view is that the Minister of Health, and especially the government, I mean, is one responsible of mobilizing funding from different parts, including private sector. And what I want to say is that for a government to be accountable for a program, you will see it in the budgeting. National budgeting normally must put money, funding for a program they are implementing. This money can come from the government itself, but it can come from different partners, but it must be coordinated. It is a funding, mobilization, coordination by the government. That's what I want to say in general, as a general picture. Maybe Prof. Bazira can complement.
Thank you. The question on financing is always a difficult one, but these are my honest views. First and foremost, when we're looking at issues of financing and investment in this area, we've also got to confront the question of sustainability. So whatever it is we're doing, we have to make sure it is sustainable. And I agree with my colleague, AMR investments must be included within the national budget appropriation process of any country. But I also go beyond just the Minister of Health, because AMR cuts across sectors. So the Minister of Agriculture, the Minister of Veterinary, services, or resources, whatever you call it in the country, and the Minister of the Environment should all include, as part of their routine budgeting, resources that are dedicated to the AMR process. Now, I think a country like Rwanda, which is a developing country, we understand the limited domestic fiscal space, and therefore the need to reach out to our partners to find additional resources to support some of these national priorities. So when we do that, they're established, and tomorrow I'm going to spend part of my time at RBC. I'm sure that's one of the questions we'll be confronting. But when we look at the available funding sources, you're going to find them within multilateral institutions like the World Bank, for example, the IFC, the IMF, the African Development Bank. But also you have bilateral institutions and relationships with specific governments. So you're going to have the United States, UK, the Europeans, Japan, China, all those countries. So as your country engages with some of these institutions at the bilateral level, our job of all of us in the room is to make sure that AMR funding is part of those set of priorities that your country is prioritizing for support if there are no sufficient resources available within the budget. But there is another piece that we sometimes don't talk about in the developing world, and that is really the research and development piece. So there are two ways we deal with financing, but also link it to the work we do in research and practice. One is, so like a lot of the presenters that I listened to were presenting their work on the research that they've done, whether it was a cross-sectional, retrospective, or maybe even something longitudinal, which is more forward-looking. The importance of having researchers connected to the practice is that you want that any emerging and existing evidence that they are coming up with gets institutionalized and routinized as best practice, so that those things are done routinely and they can be funded as part of the ongoing health system costs. Okay? So that you move away progressively from project-specific interventions, because as long as you keep in this project mode beyond, and I'm going to come to the research piece, as long as you keep seeking project funding, it means you're going to have, it's like, I like calling that working capital, and it doesn't make me popular, especially with my colleagues in the development world, is that the problem with working capital, it's like giving someone fish. If you give someone fish, it's okay. They're going to eat and deal with today's hunger, but it means tomorrow you're going to have to give them more fish, and the day after, and the week after, and the month after. So even as we implement some of these projects, we should be thinking about giving fish to the country while also teaching people, in supporting the countries to start their own fish farming. Because ultimately, that's how you sustain a lot of this work. And as you know, the appetite for development assistance is increasingly going down globally. We have not seen any increase in this. Over the years, there was only a slight increase during COVID-19 pandemic, but it quickly came back down and it has continued to decline. So on the research and development perspective side, I think this is where we need to create a partnership, especially with the pharmaceutical and biotech industry, because they have an interest in this work. If you are a company producing antibiotics today, you really want to keep marketing them for the next, for the next year and the year after. But if your antibiotic is getting useless every year, it means it is threatening your own economic and commercial interests. So pharmaceutical and biotech companies have an interest, in supporting something like this if the research that we do ends up in practice and we end up fighting the resistance and we reduce the burden. So for me, I see them as a more long-term partnership we can go to, but mostly focused on the research piece of our work. And I'll end by saying the other part where we could seek funding from, especially the private sector, all types of the private sector, is dealing with this question of the economic costs related to AMR burden. Because a lot of the studies you'll see will quote for you the global economic burden resulting from AMR burden. So it will be, productivity costs, healthcare additional costs. But this is the global picture you're looking at, somewhere close to $1 trillion every year. But I think what the Rwandan government and the Rwandan stakeholders would like to see is what are those economic costs related to AMR for Rwanda. And if you could seek funding for such studies, or for the health professionals in this room, when you are designing your studies and seeking funding, make sure you include an economic component to it, so that you're also costing the burden of this. And so this now moves us to doing more interdisciplinary research as opposed to just one professional approach to the research. Try and ask questions that are multi-pronged. Those types of research questions stand a better chance of getting funded. And then when you get the evidence, work with people who are very good at dissemination, maybe even include in your institution some communications people that will help translate your findings into a format that you can present to policymakers in a language that they understand. Because ultimately, and don't stop at your Minister of Health. I can tell you, even if my friend Dr. Sabine was in the room, I would still say it. Ministers of Health are some of the weakest ministers you'll ever find in any government. You put them in the same room with the Minister of Defense making a case for supplemental budget, the Minister of Defense will most likely walk away with the money, maybe even 150% of what they asked, while the one for Minister of Health, if you are lucky, you get 10%. Because the Ministers of Defense are able to say, this is the threat we face, the national security threat we face as a country, and therefore if you look at the investment we are looking for, it's just a pittance compared to what the cost to the country would be. It doesn't mean that the Minister of Health can't make the same argument, but it's the way we present it. If you go and you're only talking about MR, it's susceptible to this resistance, to this one, to this. Nobody understands what you're talking about. You've got to be able to say, on an annual basis, MR costs us $50 million in productivity costs and $30 million in additional healthcare costs. So we are talking $80 million, and you're addressing the Minister of Finance, okay? However, what we are asking for is that within the budget appropriation process, you only invest $10 million annually for us to solve this problem, because that will save you $70 million. So now you've moved away from talking about AMR, you are talking economics. And that's what these policymakers will understand. And I'm telling you, if we made that case, it's a lot easier for governments to fund their own AMR interventions compared to some of the other big price ticket things like HIV. HIV treatment is expensive. And my friend from Kai, I'm sure Chai is going to talk about some of the things. Those are very expensive interventions for countries. If you say we need an additional $200 million, they say, okay, we understand what you're saying, but we don't have the money. And so it's sort of like they feel sorry for you, but there is nothing we can do. But if you're looking for $10 million, the Minister of Finance looks at it and says, you know what? This is something we can afford. So I'll conclude by saying we need to make a better pitch for the private sector to fund us, for our own national governments, and then in a few cases where we look outside, we should be asking our partners to help us fund the fixed and high infrastructure investment costs. So like building up the labs, equipping those labs, but we shouldn't be asking for resources for AMR to pay salaries for healthcare workers, because those people have lost appetite for things like those, because when you pay somebody's salary and they're still needed tomorrow, you still have to pay their salary. So nobody wants to commit themselves to this perpetual mortgage where you have to keep paying. But if you say, if you tell China, help me equip all my microbiology labs so that they can be able to detect all types of MR resistance, they might look at it and say, this is something we can do. And then they turn it over to you to maintain and sustain. But if you tell them, keep funding our healthcare workers for the next 20 years, they're not going to give you $1. Thank you.
Thank you very much, Prof. Deus and Prof. Cyprien, for your very important contribution. And to Blaise Pascal, it has been said by other panelists, but you are going also to highlight how the partnership between the private sectors and the public sectors can contribute in strengthening the antimicrobial stewardship program.
Thank you, Dr. Felicite. I'm not going to talk too much because Prof have just highlighted it clearly. It starts with a collaboration between the private and public. The collaboration should always be what is the common goal, first of all, and then how do we tackle the problem. First of all, let's look at what the data are saying and do a research. Most of the research I've seen here presented were only clinical, that not translate to what the policymakers can understand. When they say the carbapenemas or carbapenem are resistant, should the Minister of Finance understand that? Should the insurer, let's say a person in Rama, understand that language? Not at all. But when you say if a patient is carbapenem resistant, he's going to stay 5 more days or 10 more days in a hospital, and the cost will be the nurses or the doctors treating him, the beds, the food that the patient will get. He will understand more because it's a cost. So if you are able to generate those data, health outcome plus health economics, and then present to the policymakers, we are going to generate a policy that are evidence-based. That's number one. And secondly, the partnership should go on expertise exchanging information and technology. Most of the innovation are coming from private sector. Let's say pharma company, they always have innovations in pipeline. How do we access to their innovation? Through the partnership. For instance, Pfizer, they came up with this idea of Accord, where they are providing their vaccine and medicine at cost basis for 45 countries in low and middle income countries. These are good collaboration between governments and the private, where they increase access to the patient, but they should be always in IMAD concern, as IMAD concern, the safety and the effective use of those vaccine and antibiotics. But as well as the capacity building, we should also learn from them, because they have expertise. How do we gain their knowledge in terms of capacity building, as well as the quality improvement of our health settings through grants that we have already provided through UR and CHUP. This quality improvement also and capacity building can come as a solution to the problem. So basically, the research that can lead to policy making, as well as capacity building, but also resource mobilization, not only for money, but as well as for human resources. So basically, these are my answers. Thank you.
Thank you very much, Blaise Pascal. Our last question goes to the representative of CHAI, Mr. Yasant. He's going to talk about challenges in building a long-term partnership for sustainable antimicrobial stewardship and antimicrobial resistance program. Thank you, Mr. Yasant.
Thank you very much, and good evening. I think it's already around 6. I think I may not add much, because the answers is most of what my fellow panelists shared already. Speaking from someone in a development partnership, which is more international NGO, when you always mobilize resources, someone will ask you, what is the impact of the funding that I'm going to give you? So you should be able to quantify how much lives are you going to save against the money you're going to invest. And one of the challenges we have in terms of EMA, things are still vague. It's still more emotional. It's still more people talk about it, but you can't quantify it. And you can tell from the 5 presenters here, or the oral presentation, the research, none mentioned the money. And as we said, in financing healthcare in developing countries, resources are always scarce. It's always like there's always something missing. Then, as we're trying to look what could be the challenges, it's more, there's a lot to be done, being a multi-sectoral, multi-layers, which is more, as we said, agriculture, wildlife, and then we have human as well. And we have climate change, which is also on the top of it, which is also still a complex part. We know the intervention that works. Those interventions that works should be on the right platform. The reason I will say this is because if you know what works, at least you can advocate for that to be well funded. From what we're doing now at CHAI, we are working with RBC to set up a One Health digital system that will combine data from wildlife, more with RDB, and then you have a component for agriculture and livestock with lab, and then we have RBC. At least to have some of those targeted interventions based on where the issues are, based on what is being reported in the system. Second, something that what I see is more, as we said, we have different intervention at different levels and different needs. What the hospital needs is different from what the policy level they need. It's different from what the veterinary need, but at least we should see where we're making more savings and where we can allocate more of our resources. So those vertical intervention, most of the time they kills the system, as I was saying. He mentioned about having MTN on a productivity side. I will add to that where we need to have all health insurance part of this. As I have someone who's going to go home after taking 3 classes of antibiotics, if the person goes home only on 1 antibiotics, I'm saving on the 2. But if I save that money, where that money goes? Because that's the money they're supposed to be doing for those who are investing in AMR. But we don't have those numbers. You can't tell RSSB, which is managing a limited pool of funding, or I need 100 million to invest in AMR. They will ask you how much am I saving or how much am I making from this investment. So we are lucky enough to have academician here. One of the presenter, the oral presenter, he mentioned about data, AI, because the study we all saw how long they are taking. If we plug machine learning, we can have the projection quickly in a day or 2, just predictions based on what the data are flowing coming from the system. And then we know we can compute how many lives we can save. One of the guy mentioned that we are about to lose 10 million annually in terms of lives. But if we can avert those deaths, how much are we going to have? That money can be easily invested. COVID only killed almost 14 million globally, and people rush to do more of those interventions, so that means we still have a room where we are. In a country where I spend most of my time these days, you can't have antibiotics. At least you have to visit your GP 3 times. You will never have antibiotics until at least you went to the 4th time. For that reason, in the morning, panelists mentioned there are other interventions that we know wash, that can work. There's somewhere we need to exercise, maybe your immunity was a bit low, and then you're back, you don't need antibiotics anymore. But pharmaceutical companies like Pfizer or GSK, they are willing to invest because they know some of the antibiotics they have, they can be saved before they become resistant. Or, as we all know, there's no potential candidate for antibiotics in the pipeline for the manufacturers. That means we know we are heading into that big pandemic, which will be around AMR. He said it's a silent killer, but now it's up to us to make it more a noise killer. But you can only make a noise killer if you have data. I know there's some good intervention. I will flag something beyond AMR. I know CHUB recently they've done a good job in reducing neonatal mortality. Develop a good framework, but no one knows about it. And we have other many hospitals that are facing the same issues. Can someone see to frame that? We package what will cost. For the people who are putting more money in MNCH services, we say, look, we need to fund this kind of package interventions to other hospitals. We had the neonatal wards everywhere, but that can work. The same thing for AMR. We can do that based on if we manage to build list package, come up with a good framework of what works, and then that will help us to run away from those challenges. There's no enough resources for health, especially in developing countries. But there's always funding when we know people, we are having a bigger impact. So I'll pause there. Thank you.
Another round of applause for the panelists, please. So this marks the end of this panel discussion. Thank you very much, everybody, for your contribution. I think we have learned a lot. And let me give again the microphone to Dr. Tope to continue the next session. Thank you.
Thank you very much. On behalf of the DG, we'd like to appreciate our resourceful panelists for the numerous interventions that have been proposed. So before we can see that we are getting ready for the cocktail, we would like to have a group photograph. The DG, Dr. Joe, well as Dr. Jubre, the group photograph. Thereafter, we have like a few minutes to stretch our legs. Then while we wait for the cocktail setup to be done in about 10 minutes or less, once the cocktail is served, all presentations that we were supposed to take after this session, just about 2 of them, we want to humbly request that we have it in the morning tomorrow. So tomorrow, we'll be having the concluding part of the oral presentations, as well as the poster presentations, and then we'll wrap up. So we expect that we'll start as from 8. By noon, we'll have our lunch, and then we can say goodbye to the ancient city of Uye for us to meet at another time. Thank you very much for your time. So the DG and our resource person. So all the other participants can please, we have bottled water available. Just stretch for about 5-10 minutes. Thereafter, we'll be invited here for the cocktail, and then we can wrap up for today. So we expect that between now and 6:30, we want to wrap up the session finally. Thank you very much. Prof, please, we kindly request that we join the team, sir. Thank you very much, sir. I also request that I also join. Thank you. Well, please wait. While we wait for Prof, please don't take don't take any shot now until Prof is there. Yes. Thank you. Very much. So please, we thank all our online participants for the patience. We may request that we meet tomorrow as from 8 a.m. Between 8 and 9, we'll have the registration and all other necessary arrangements. By 9 on the dot, the sessions will start. So please, we want to encourage that we arrive very timely tomorrow to enable us conclude by lunchtime. By lunchtime, to want to round off all the sessions. So please, let's stand up for a few minutes to stretch. Let's network. We have very busy persons available here. It may not be very easy to see rep from Fleming, rep from Chai, rep from all other organizations that are here, from Pfizer. So please, let's network. Let's try to seek for necessary partnerships, collaborations as it's anticipated. So those of us with our poster, please, let's drop the poster, the hard copy, the printed hard copy at the reception desk while we continue the scientific session tomorrow. The result of the scientific session 2 will be announced after the sessions tomorrow. Yes. Yeah. So please, in about 10 minutes, the cocktail will be ready. By 6:30, we want to close for today and then reconvene tomorrow, 8 o'clock. Thank you very much.